All right. Hello. Good morning. No rush, but if you could kind of slowly make your way to your seats, we're going to get going. My name is Steve Elrick. I'm with Solid Blend Technologies. I'm going to be your MC for the day, so I'll try and keep things moving forward as per the agenda. Try and keep things engaging if I can, to the best of my ability. But first off, just a couple quick kind of traditional housekeeping items. Cell phones, please put them on vibrate. If you need to step up and step out for a call, that's fine. Please do that, and just kind of be respectful of the speakers and what's going on in the room. If you haven't been around the facility yet, we've got restrooms over here to the left of the bar. We've got snacks and coffee and drinks back here behind the kind of IT setup. In the red barn, we've got vendors set up, so please visit the vendors on break or when we've got time kind of to split apart. We've got another vendor set up over here, which is where kind of the social hour is going to be held, OBR Cooling Towers. And then Solid Blend has a booth right over here to my right. So I really just wanted to start out by saying thank you so much for spending some time with us today, and to the folks virtual, to you as well. This is a topic that we're very passionate about and we spend a lot of our time talking about. So being able to educate a group of people like yourselves is just an honor, and we really appreciate you taking the time out of your schedules to spend a day with us, spend the day with what we view are some very quality speakers around some very important topics for you all in the facilities that you work in or in the public health sector and some of the things that you guys are dealing with and seeing day in and day out. So just a quick overview of Solid Blend Technologies. We were founded in 1999 in Dayton, Ohio, so we've been around for about 25 years. When we started our journey, we really started focused on HVAC water treatment, so steam boilers, cooling towers, treating those types of systems, which from a hospital perspective, I know there's a lot of hospital folks here, so I'll probably speak to that facility type quite a bit. Very critical to your operations from a sterilization standpoint for your autoclave surgical equipment, very critical for your cooling, humidification of your surgical suites, also just critical for keeping your clients and staff happy and comfortable as they go about their day. So we spent probably the first decade of our life in business really focused on that type of work. And then we saw a need to really start to shift gears and not stop doing that, but also add to our kind of tool belt the ability to look at waterborne pathogens. And initially, we kind of always did that in cooling towers, making sure that water was safe. But we thought, we were doing our clients a disservice by not looking at the potable water, which is where a lot of the issues lie with this type of bacteria. So we've been doing this for a long time. We pride ourselves in our service. We pride ourselves in our response time. And we would love to chat with you more about helping you in any way we can at your facilities or as a resource for public health. So thank you. Just a brief overview of the speakers and the agenda for today. So we've got 4 speakers, and then after the speakers are done, we've got a panel coming up. So with that, I'd like to ask one thing of you all. So if you could just think to yourselves, rate yourselves on a scale of 1 to 10. Today is all about water management. So water management from our perspective encompasses both of the services that I just described. Treating HVAC systems, which is critical for the operations of a facility, as well as domestic water and waterborne pathogens. Knowing those 2 topics, which is what we'll be talking about today, rate yourself on a scale of 1 to 10 of how well of an expert you think you are in those subject matters. 10 being I know everything, 1 being I know absolutely nothing. And then think to yourself, what would it take to get from the number I am to the next number on the scale? Because we're not going to be experts when we walk out of here today. And then I would ask you to just set an intention for what you would like to learn. Why are you here today? And then I want to check in with you throughout the day on that and make sure that you're getting satisfaction on what you're here for. And if you're not, I'd like to connect you with a resource that can get the information you're looking for. So my intention today is to meet as many people in this room as I can, make friends, have fun, and connect you guys to the resources you're looking for. So with that, I'd like to call up our first speaker. I'm going to flip to his bio so I can read it correctly. So we've got Doug Dolder. He is a Solid Blend Technologies employee. He is our operations manager. So Doug Dolder started his water management career in 1991 by joining the U.S. Navy as a boiler tech on a Knox-class frigate. He attended the ASSE School for Officer Training, the University of Cincinnati and Cincinnati State, where he studied environmental engineering. He was certified as an ASSE 12080 Legionella Water Safety and Management Specialist in 2020. His wide-ranging experience includes Legionella case investigation, domestic water remediation, water management plan creation and implementation, monochloramine public water system disinfection design and management, HVAC water treatment service, soil and groundwater investigation, and remediation and regulatory compliance. He's been married for 28 years to his wife, Bethany. They have 2 children, Kate, who studies law at the University of Denver, and Stephen, who attends the Hobart Institute of Welding Technologies in Troy, Ohio. So without further ado, I would like to bring Doug Dolder out and get him going.
Man, when you signed up for this, you never expected that. That is Molly Hatchet. Oh yes. So, thank you very much, Steve, for introducing us. And glad to see everybody here. A lot of new faces, and that's great. Like Steve, I hope to shake every hand and meet every person here before the end of the day, because we really want to know, how can we help you? How can we better educate you about water management? Hey, good morning. Glad you're here. Water management programs for Legionella and other waterborne pathogens in water systems. It sounds big and crazy. It really isn't. You'll notice throughout the day that all 4 speakers have areas that will overlap, because we're really talking about water management. We're talking about waterborne pathogens. We're talking about mechanical systems. And we're talking about regulation. So everything is kind of overlapped. You'll see some of my slides. I'm probably going to move through a little bit quicker, because I know that Dr. Stout, Dave, or Bryce will be covering those later today. That's me. I'm the operations manager. I've been with Solid Blend for about 3.5 years, and I've been working in, on, or with water for most of my life. Started in the Navy. Facilities that choose not to use the tools available to them to manage waterborne pathogens in their water systems are flirting with disaster. That's the song I just played. If you actually read the words, the lyrics, they're kind of described if when something happens and we're reacting to an outbreak. Kind of interesting. But remember that quote: if we don't use the tools that we have available to us, then really we're not managing the risk, and when things happen that could have been prevented, flirting with disaster. Legionella in the news. You're seeing this more and more. Legionella outbreaks and Legionella-related illness is in the news, and these are just some of the ones from 21, 22. I did put in Grove City, Mount Carmel, because that was one that kind of really came to the forefront here in Ohio. But it's all different places, all different things, all different causes. Cooling towers, domestic water systems, turning water heaters down or lowering temperatures as a cost-saving measure in Latvia. So there's all these things kind of work together and can be potential risk, potential causes for waterborne pathogen outbreak. And of course, we've got some locally here, some folks that are dealing with that now. So it can happen to anyone, anywhere, anytime. Legionella bacteria, Dr. Stout's going to cover this way more than I do. But 12 to 70% of hospital water systems, we can find Legionella bacteria. 60% of large high-rise buildings, usually 10 stories or higher. 10 to 40% of residential homes, and then cooling towers. Cooling towers, 30 to 50%. So it kind of averages out that 50% of structures and buildings and cooling towers have active Legionella bacteria in them. So that's a pretty big number. And everybody here has either a cooling tower or a domestic water system or heated water. Maybe you're with public health, so you're working with folks that have those things. So it's very, very prevalent. You don't always see it in the news, but we're starting to see it more. Dave Christopherson is going to talk a lot more about this, but we're concerned about piping systems, warm water, and the design. Most of your buildings are designed to grow bacteria. That's not that that's the intent, but that's what happens when you have these large, complex water systems. You're trying to maintain disinfectant level, temperature, and flow all the way through them. And when one part of that trifecta breaks down, it really kind of cascades on itself. It creates the perfect environment for waterborne pathogens to grow and colonize. Decorative features, spas, showers, sinks. A lot of people say, well, how can I get it from a sink because I'm not washing it? It happens, right? Water doesn't need to be boiling to steam. So you see that sometimes in sinks. We're fighting sometimes with scald protection regulations, right? So Legionella can survive up to 122 degrees. Most of our scald protections in the state of Ohio, if your healthcare facility is 120. So we kind of run that balance of making sure we don't burn people, but also managing the risk of waterborne pathogen growth. Some of the things that we have gone into more is seen, we saw it during COVID, we saw it during sort of the push to make buildings green with water conservation, energy conservation. So when I said the trifecta, what I'm talking about is you've got flow, disinfectant, and temperature, right? All three of those have to be in the right ranges in order to manage the risk of pathogens growing. If one of those drops out, then it really affects what's happening. So low flow, we're going to go to waterless urinals in our high-rise building. Okay, so we're now not moving the amount of cold water through the building, so that cold water can be stagnating, and the cold water feeds the hot water makeup. We're going to use low-flow aerators on our sinks to conserve water. But the building was designed to move at 1.5 GPM through that fixture. So now we're restricting the flow, water stagnates more, water age increases. Temperatures it has a wide range, so it's always a constant challenge when you have these large, complex systems to make sure that you are heating the water properly, because hot water should be hot, cold water should be cold. Other things that can contribute to that, reduction in hand washing, certainly during COVID. We're not using hot water, so we're not moving it. Again, stagnation. Temperatures drop, disinfectant drops, and there's no flow. Dead leg piping. We cut off pipes and cover over them with drywall, and they're there, but they still have water going through them. So now that whole area can be an area where we're really incubating bacteria. Unoccupied areas in buildings. We'll talk a little bit about flushing and protocols a little bit later. So this is the range. Again, Dr. Stout's, I'm sure, going to cover this a lot better than I do, but this is the general range for when you see. So you can see that Legionella growth range, 68 Fahrenheit to 122 Fahrenheit. That is a large range. Really, really is. So if you're at that 118, then we really need to make sure we're turning the water over, making sure we have good disinfectant. Ideal growth range is 95 to 115. Grows rapidly. And a lot of our hand sinks, it's there. That's where we're at. Dave's going to talk about this, I'm sure, but cooling towers are probably the #1 risk when it comes to outbreaks. You see it all the time because we have warm water that we have water that we're cooling, but it's in that range, and then we're evaporating it, and the bacteria can travel with that evaporation and drift more than a mile. We're going to kind of go through this very quickly. A lot of things can contribute. You need to make sure, the folks, we are always cleaning cooling towers. We have a vendor back there, that specializes in that with us to actually clean and disinfect the towers to make sure that we're not providing nutrients and things for bacteria to grow. All right, so when we're talking about being proactive, a water management plan, water management program is the #1 way to be proactive to help manage the risk of waterborne pathogens in your equipment, your facility. So we're seeing an increase in Legionella positivity across the board. You're seeing it more and more, not just in hospitals, not just in assisted living. You're seeing it in schools, office buildings, cruise ships. You're seeing it everywhere, right? People are getting sick because Legionella is growing. A water management plan will give you the tools to help safeguard your water and manage that risk. A good comprehensive plan. In most cases, it's recommended or required. If you have an accrediting body that comes and surveys your facility, most of the major ones for healthcare require you to have a plan that meets certain criteria, right? CMS, if you take Medicare or Medicaid funds, have to have it. Joint Commission, have to have it. ASSE, HVAC, have to have it. Even if you don't have to have it, it's the best way that you can help protect and safeguard your employees, staff, the public from infection. And we'll talk a little bit about routine monitoring versus case investigation, which I know that Bryce is going to delve into a little bit deeper. Like I said, recommended or required. If you look at all of these directives, whether it's the ASSE standard that talks about HVAC equipment, the Veterans Hospital 1061 directive, Joint Commission, ASSE, and the CDC. All these folks are saying you need to have a water management plan in place, and it needs to be implemented, and you need to be using it and reviewing it to help protect against waterborne pathogen outbreak. So CMS, these are some of the requirements that you have to do, and the first thing is you have to conduct a risk assessment. Anytime that you suspect or you have someone test presumptive positive for Legionnaire's disease, they're going to want to do a CDC leaf assessment, and that's where someone comes in and they look at your building top to bottom, front to back, building use, building history, water systems, patient population, testing, and it identifies risk areas. It's a very comprehensive document, and you'll use that to build a plan from. But this document is going to help you identify, well, if I've got a problem, where might it be? And we're talking about, we talk a lot about Legionella, but it's waterborne pathogens because we're starting to see other waterborne pathogens pop up as well. Specifying testing protocols, maintaining compliance, all of those things are part of what CMS requires. Now, CMS does not require you to take environmental samples for Legionella analysis. CMS does not require that. They require everything up to that, but they don't say you have to take samples to prove that you don't have Legionella in your system. Joint Commission. Last year, they changed the terminology in their directive from minimize waterborne pathogens to manage waterborne pathogens, and you're going to kind of see that trend. I'll talk about that in a little more detail here in a minute. Program team, WCRA, flow diagram, water use, flushing protocols, control ranges. We're going to talk about each one of these and how it applies to the water management plan. Again, does not require culturing for Legionella. ASSE, which was, they merged with HVAC, so this is your acute care hospitals. A lot of the same stuff in there. It's interesting, though, because they just came out with a new standard for surveyors, and it has all these bullet points of things that the surveyor should be checking for in the water management plan. It's not a bullet point, but one of the paragraphs has the sentence that says you have to be able to implement and validate the effectiveness to include environmental testing for pathogens. So they're not saying you have to pull samples, but they're getting closer in their language. Because honestly, the only way to validate that any plan or any system is doing what it's supposed to do is to test and verify. So you verify through monitoring activities, but you validate by taking samples. If you don't hear anything else I say today, please hear this. 0 Legionella is not the goal. 0 people getting sick, that's the goal. And I'll tell you why that is as we go through. 0 Legionella is not the goal. 0 people becoming sick is the goal. So the risk assessment we talked about, conducting the LEAF. There's also a water infection control risk assessment, which is another document that CDC has that, especially for you infection preventionists, it helps you to identify your patient populations and assign them a risk factor for waterborne pathogens. So you're going to go through, you're going to look at your this wing, they do oncology or transplant, things like that, and you're going to assign a risk to them to see some patients, some are going to be more susceptible based on their symptoms, conditions, things that they have. Implement a water management program, all these standards, control measures, physical controls, temperature management, disinfectant, visual inspections, and environmental testing for Legionella. All right, so this is kind of the meat of what I'm talking about. When you are creating or having a consultant create a water management plan for you, there's 7 elements that need to be there. Now, this is coming from the CDC. We actually add a few more to ours to make it more comprehensive and user-friendly, but these 7 elements have to be there. First thing is a water management plan program team. Identify persons responsible for development and implementing the plan. These are typically your folks from administration, infection prevention, facilities. You've got clinical side, because we're also, if we have a suspected outbreak, we're also doing clinical surveillance of our patients or folks in our care. It could be certainly the consultant that designs the plan should be on that. And these are the folks that are responsible for implementing the plan, verification and validation activities, and reviewing and changing the plan if necessary. Very, very important. That's the first element. The second element, which is developed from that CDC LEAF assessment that I discussed, is a water systems description, a written description, and a flow diagram. So when a consultant comes in, they're going to look at your building. They don't necessarily have to see the plumbing prints or structural diagrams, things like that, but they need to be able to understand when the water comes in from your supplier as cold water into the building to the point where it leaves through the sanitary sewer, what happens to that water? How do we heat it? How do we store it? How do we move it? How do we monitor it? How do we sample it? What's it used for? Right? So we develop all of that and have that description so that anybody can pick up that plan and look at it and say, oh, so the water comes in here, does da-da-da-da-da, and then it leaves here. It's required, and it's very, very helpful, because from that diagram, we're going to assign control points, monitoring points, things that we need to be watching, monitoring for potential risk. The third element, water system hazard analysis. Identify areas where Legionella could grow and spread. These are areas that have a higher risk. So when you're looking at any typical water system, let's say you have, the way that you heat water is you have a hot water tank, just like we do in a house, or where we have water, we store it, we continually heat that. When you're storing the water there, you're not necessarily moving the water. You're keeping the temperature up. The disinfectant's probably very, very low, because as you raise the temp, chlorine and halogens dissipate quickly. But that would be an area to say, so 2 legs of that trifecta, we may have a problem, so we need to really pay attention to these. All right, looking at a return pump. So if you have a return pump that is not functioning, is valved off, does not work, you're sending the water out, but it's not recirculating to get reheated and reused. So again, you're messing with the flow, temperature, and disinfectant. So we actually identify the water system hazards, and we assign these. It's either a monitoring point that we can monitor and get data from, or it's a control point where we can actually change what's happening there to affect the temperature, the flow, and the disinfectant. Fourth, control ranges, just what I said. So there are standards that have been validated through studies, through practical application to say your water should be this temperature in order to meet the minimum standard for controlling waterborne pathogens. So if you have a hot water tank, you're always going to hear me say it should be 140 degrees minimum every time. Well, we don't have a mixing valve, so we can't send it out at 140 to our sinks because of the scald protection. Okay, let's talk about putting it in a valve, because you don't want your tank at 120 because Legionella can survive up to 122. So there's these things that we have to work around, but we can establish the control ranges that when we're checking, if the temperature is too low, it's out of range, and we have to do something about that. If the return pump is not working, we have to do something about that, which is my next. The fifth element, corrective actions. Your plan should have a written action plan that if this happens, this should happen. If this temperature is out of range, this is what I should do to fix it. If I detect Legionella, this species here, this is how I deal with that, written right in the plan. The sixth, verification and validation. I touched on this a little bit. Verification is when you're going through and checking all of these monitoring and control points. You're checking temperatures, you're checking chlorine, you're checking to make sure that the pumps are running. Everything is functioning as it was designed. Validation is environmental testing, water samples, swab samples. So you verify that the plan is working the way it should, but you validate that plan by saying, well, there's no Legionella detected, or there is Legionella detected at a level that we can manage. And seven, documentation. Everybody here has paperwork. Important, important, important to document everything you do. If you have folks that are flushing sinks weekly, should be documented. If you have to do a corrective action because you had to replace a hot water tank, document it. Water samples, document it. You have it all right there so that in the future, if something does happen, you can show what you've done to help manage that risk. So those are the seven that the CDC says, hey, you should really have these. You've got to have these, otherwise your plan's not going to be comprehensive. Additional elements that we kind of put into our plans, we worked very closely with the Ohio Department of Health when crafting our plan template to say what else needs to be in there, what's going to be helpful to people that are creating these plans and implementing these plans. One section that we have is what happens if we have someone get sick, if we have a presumptive positive case. What do we do? We have a lot of folks here from public health. There are very specific things that if you meet the criteria of a case investigation, the CDC's criteria for that, there's very specific things that you have to do. We put it right in the plan. That way there's no surprise that if this happens, this is what the expectation is going to be from the regulatory side. So if you have somebody who is presumptive positive, it meets the definition of a case, and the potential is there that the facility could go under water restrictions. Now, what does that mean? Water restrictions, you either A, have to put some type of filtration, point of use filtration, on every point where you're going to use that water. 0.2 micron filtration that will filter out pathogens, bacteria. Or you can't use the water. So I know we have a lot of folks here from healthcare And some have experienced when someone comes in and says, you have to do this or you can't use the water. Can you imagine not using the water in a hospital? That's terrifying. I've seen it happen. So that's one of the first things. If it's determined that more likely than not that the person contracted it there while we're going through the process, you're going to have to filter. So that's in the plan. You're certainly going to pull samples and get those out as quickly as possible to make sure, what are we talking about here? In the meantime, we may require some type of remediation. Now that could be a chemical remediation, hyperchlorination, monochlorine, chlorine dioxide. It could be flushing. It could be plumbing modifications. There's lots of things there. And typically, the Ohio Department of Health will say, you need to discuss that with your consultant and come up with that. Come up with a plan, submit that to us. We will approve that or talk more about that. Once you have done those things and you think everything is good, then you have to pull additional samples to validate that, yes, we don't have a problem here. All that is written in the plan, that this is potentially what could happen, worst case scenario. Usually, if you have a presumptive positive and it's a case investigation, your current water management plan. Now, I will tell you, I've done this for a while now, and I go into situations, Chris Miller does too. We go in and say, do you have a water management plan? Yes, we do. Okay, can we see it? Sometimes it's a great plan. Maybe it's just not implemented correctly. Sometimes it's a policy where they've taken things from the CDC toolkit to kind of say, these are the things that should be done, but we're not doing them. Sometimes there's no policy at all. So again, there will be comments about that you need to have this comprehensive plan that has those 7 elements in it. We talk about contingency plans, and if we see this species, we do this. That's all should be a part of a good comprehensive plan. Flushing protocols. With the start of COVID, and it continues now, we've got spaces, hospitals, wings, buildings that are unoccupied. So the fixtures there are either underutilized or unused. So we have to put something in place that says every so often we are going to flush that to bring water through the building, get flow going, replace the disinfectant, make sure the temperature is correct. Flushing is very important. Now, flushing, if that's the only thing you're doing to try and get rid of a known waterborne pathogen outbreak, hit or miss. Usually it requires something additional on top of that. But once you get things cleaned up and are in good operating order, flushing is a great way to maintain that. It's a must. This is an example of one of our flow diagrams. So this is straight from the CDC. And you can see, it doesn't work on that. Anyway, the top line is where the water comes in. Then you've got green, which is the cold water distribution, goes out to water fountains and sinks and other areas, HVAC makeup water. The yellow is where it's heated. It's tanks, boilers, whatever. That's where it's heated. And then the orange is the distribution, where it goes out to this wing, these sinks, these showers. It shows all of the returns, all the areas where you can measure and take temperatures and monitor. And then the red at the very bottom is the sanitary sewer. Watching my time here just because I tend to go long. And I know there's somebody here that's going to start doing this, staring at me. So this is the same type of flow diagram, but just the hot water system. So you see we break it down a little bit more. We actually name and number every component within that hot water system. And then we've got areas where if it's a blue and a red circle, that's stagnation danger, potential hazard there. T, we can measure the temperature there. And then the dotted lines obviously are the returns coming back. So we map the entire water system. So this would be the hazard analysis portion of it, where we identify the point by number. What's the name of it? Is it a control location? So if you're looking at something, let's say from the city, right, and you are looking at the water main, is that something that we can control at the facility? Not usually. We can call the city, county, and say, hey, we're not getting enough chlorine, it's not cold enough, whatever, but typically that's something that we have to monitor, and somebody else controls that, right? So you've got monitoring points and control points. A hot water tank would be a control point because we can monitor it and see if it's out of range, we can make a corrective action and control it right there. So those are all laid out. And then what is the hazard? Why are we concerned about this? There's a description in there. And then with our plans and most plans, there is the documentation. So this is how often you have to check these locations for this, this, and this. Most people do this electronically, but you gotta have the documentation that says, we've been checking this, nothing's been out of range, so what else could be a potential problem? All in the plan. Why sample? Not all Legionella have the same risk. Dr. Stout's probably going to talk to you about that. The one that we're concerned with is Legionella pneumophila, specifically SEER group 1, but also 2 through 15. Those are the ones that have the highest incidence of leading to illness, including Legionnaire's disease pneumonia. Other ones we're concerned about, but maybe not as much. You have to evaluate that. What level of Legionella is present? So this is where I'm talking about, you're kind of seeing this shift. So previously, in a monitoring situation, the goal was 0 detections, right? And you write in your plan, when you're sampling, what do you expect, what criteria, what threshold do you have to meet? And some places will say, well, if we have positive Legionella detection in 30% or more of the fixtures that we test. So in a water system, the minimum is 10 fixtures, 10 points. So 3 or more, you're above that 30%, because studies have shown, a lot of studies over time, that once you hit that 30%, the incidence of illness spikes dramatically. So you want to know, how many do you have? Now, the CDC used to be, okay, it's non-detect, non-detect, non-detect. Now, with their multifactorial approach, what they will say is, in potable water, if you have a detection of less than 1 CFU in few of many fixtures. That's exactly what it says. So I'm good with it. When you give me numbers and says, okay, less than 1 CFU, I understand that. When you say few of many fixtures, wow. So what we go with is, we go with that 30%. Okay, so if I've got this, so if I have, if I look at it, I want to know what species it is, how much is there, and where is it at, right? We're not going to test every sink, but that gives us an idea of what we're dealing with. But again, it's kind of this stance where used to be no detection, any species whatsoever. Now we're kind of changing that and saying, you know what? The goal is not 0 Legionella in water. The goal is no one gets sick. Environmental sampling is the only way to validate that a water management plan is implemented and effective at controlling Legionella and other waterborne pathogens. Routine monitoring versus case investigation when you're talking about, why should I do a water management plan or program? In our experience, when you find Legionella detected in the water during routine monitoring, it means that you have a consultant coming out every quarter, every month, twice a year, whatever it is, and sampling your water. When there's a detection, it is much easier to deal with it at that point. Because typically, your public health departments are not involved, right? If you detect it but nobody's sick, they're so busy, you know, that's not something that you would involve them in. It's usually when someone gets sick that you have regulatory step in. Doesn't mean we don't do anything about it, but it's different, right? We can address it with the facility and the consultant. You can do things to address it immediately. That's the best way to do it. It's least expensive. It's being proactive before someone gets sick. You know, everything is different when you're doing routine monitoring. Case investigation, completely different. Somebody's already sick. Now, hospital administration, regulatory body, they're driving the boat. Okay, so now someone is sick, you have to do this, 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 and this. Just like I said, there's those steps that are in the plan. So again, it's sort of out of your control. And when you're in a case investigation, especially when you're dealing with point of use filtration and some of these things, they can get very, very expensive very quickly. But it has to be done to protect the public, patients, and employees. We talked about what the different things are. You know, again, negative PR associated with a presumptive Legionnaire's disease case. One of the things that you will be required to do is notify staff, patients, put up signs, things like that. So about a day or two later, you're going to get a call from the media that's going to say, hey, we heard you had this, and you have to address that. Now, we can certainly help you through that because we've worked with facilities that have had that, and they've done what they had to do, remediated, gone through all the steps, and people are back going to that hospital. They're not going to stop going there because of this thing. But we don't want it to get there. We want to make sure that we handle it before someone gets sick, because that's the goal, 0 people sick. All right, I'm just going to run through this. So what if we find it? We look for engineering deficiencies. This is all during the site survey and the assessment. Remediation, what are we going to do? It all depends on what species, how much, where is it at, what are we doing, right? Hyperchlorination is very quick, very cheap, very effective, unless you have biofilm. Chlorine will not tackle biofilm by itself. But we have, there's all these options, temporary or permanent monochloramine, liquid chlorine dioxide, point of use filtration. You put a point of use filter on there, that water is immediately safe for use. Immediately. You don't have to do anything else, and it gives you time to work through these other things. Some things that I just wanted to share. We're not responsible. Someone's gotten sick, or we've detected Legionella. We're not responsible because we're not required to test for Legionella, so we're not responsible if our building has it. False. The building owner is the responsible party if there is an outbreak due to waterborne pathogens. It's the building owner's responsibility to manage that risk. If we don't test for it, we won't find it. Therefore, we can't be held responsible because we didn't know it was there. I've heard it. Again, false. Do not be afraid to take samples, to let your consultant take samples, because if they find it, we can deal with it right then before someone gets sick. Always, always, always take proactive, routine monitoring samples. Our building is so new, it can't have Legionella. Mount Carmel was, what, 4 months old? Right? And I've seen it in brand new buildings. It happens. Doesn't matter. If you're not dealing with good flow, good temperature, good disinfectant, any building is susceptible. We don't have the budget to pay for a water management plan and samples. My response is, can you afford the consequences? If you look at my first slide where Verizon, who owned these towers and these buildings, multiple millions of dollars that they've had to pay out when they could have probably done something under $20,000 just to take care of that. And just to think of somebody getting sick, someone dying, it's a huge responsibility. Some resources, the Ohio Department of Health and OEPA published a joint memo document in COVID that really talked about what you should do when you're reopening buildings. That has some great flushing information in it. Plus, we have a very comprehensive flushing protocol. ASHRAE 188, ASHRAE 12 talks about cooling towers and plumbing. That's more the mechanical side. CMS document, Joint Commission document, the CDC toolkit. Everything that we do and any good consultant would do is they're driven by what the CDC says. That's what we do. And that's me. That's all I have. And I finished a minute early.
Can you advance to the trivia slides for me?
Yes, I can advance to the trivia slides for you.
So real quick, one of the things I forgot to make mention of is at the end of each speaker, we will have a set of trivia questions. We've got some solid blend swag bags for those who answer the questions correctly. So each of the speakers provided us with some trivia questions. Hey, Doug, real quick, if you'll come right back. We did have one question from our virtual audience. You can just use this microphone. So we had a question come in virtually. If Legionella is detected on routine sampling of less than 1 CFU per milliliter, is there a recommendation for remediation, for example, flushing or chlorination?
Sure. So if I look at, or Chris comes across that, we're going to look and say, all right, we found it in one spot. Did we take the appropriate number of samples to be representative of that water system? If the answer is yes, then we're kind of focused in there. We may look at replacing the fixture, replacing the aerator. We may look at a localized chlorination of that and heavy, intense flushing. So when you detect Legionella, it does not necessarily say you've got to come in and chlorinate my whole building. No, we're going to look at it. What's the species? If it's a blue-white species with a very low risk of human illness, we're going to treat that differently than we would Pneumophilus here, group 1.
Thank you, Doug. Again, round of applause for Doug. Thank you very much. Yep. So the other thing I didn't mention was at your table you have a passport card. It just looks like a large index card with all of the vendors listed that are here on display today. We encourage you to go visit with them, learn about them. Once you stop by and chat with them, they'll give you a check mark on their logo. At the end, once you get all your check marks, you'll put your card in this clear box. We've got 4 Yeti koozie cups available for raffle at the end of the day, as long as with 4 Amazon gift cards. So just some small prizes for you guys as well at the end of the day. So true or false, you all can read, but all healthcare facilities are required to take samples and test for Legionella. Okay, I'm going to have to call on somebody so we can pass out a prize. All right. All right, can you roll me to the next question, please? True or false? The goal of every water management plan is to ensure Legionella is not detected in water systems. Got a false. That is correct. You got one more?
What's the goal?
Yeah, what is the goal?
0 cases, 0 people getting sick.
2 of the 7 elements of a plan. Right here. Correct. Thank you very much. Swag bags, grab 3 of them.
We had another question.
Okay, one more question while Lindsay passes out. Lindsay, those go right here. Yep, in the pink, right here in the front, right here in the front. One other question is, once a person in a commercial facility is diagnosed positive, who has the regulatory jurisdiction to require water sampling? Local health departments, state agencies, or any agency is the question.
I will defer that to our next speaker. I think I know the answer, but I think that's more in his realm, so I'm sure he will cover that during his presentation. If not, I just put him on the spot. So,
thank you, Doug. Okay, next up we have Bryce Kerr with the Ohio Department of Health. I will. Bryce Kerr is an environmental specialist too with the Ohio Department of Health, the Bureau of Environmental Health and Radiation Protection. So Bryce has a Bachelor's of Science degree in biology from Appalachian State University and a master's degree in biology from Middle Tennessee State University with a specialization in ecology. Bryce began working as an environmental program specialist for the Ohio Department of Health on Legionella and harmful algal blooms in 2018. At this position, Bryce works to coordinate Legionellosis environmental investigation response throughout the entire state of Ohio. So without further ado, let's get Bryce Kerr up here.
This is that ice cold Michelle fight for that white gold. This one for them hood girls, them good girls, straight masterpieces.
Yeah, this is important.
Stylin', wildin', living it up in the city. Got Chuck's on.
Can everybody hear me okay? Yeah, I was curious what would play. I said I had no preference, but that's generally because I'm pretty anti-fun in general. Also, sorry for not dancing. I tried my hardest to find anything in our state policy that prohibited me from having music or anything else in that regard, but... So I'm here to talk a little bit about investigation response. We mentioned earlier about regulatory agencies or the regulatory sector of ODH, which actually isn't me, though it kind of is. I could still, or the Bureau of Environmental Health and Radiation Protection can still to some degree work with medical director or the governor's office or the director of ODH. In response to cases, but generally when we talk regulations, we usually mean the Bureau of Survey and Certification, who do the enforcement of what's required and enforce CMS, that CMS memo that was mentioned earlier. So my presentation today, I'm going to talk, initially I'll just show some figures that Ellen Salahi, who if you ever have an investigation, unfortunately, she'll be kind of our epi side of things. She's prepared from our data up to 2021 to talk a little bit about Legionnaire's disease in Ohio and just trends around the country. And then I'll move into kind of our investigation response when there are cases at a facility. I've generalized it for any type of facility. We usually focus on healthcare, but to some degree it applies to all. But when it comes to full investigation, that's usually when somebody never leaves the facility, which we only really see in healthcare or in correctional facilities. So I'll go ahead and get started. Just briefly, very light background because everyone was covering it, though I think it'll be entertaining if nobody actually talks about Legionellosis because we all assume that somebody else will. So exposure to Legionella usually occurs through, though there's multiple routes of exposure, through inhalation of aerosols, often emitted from cooling towers or sinks or showers, etc. It's caused by Legionella pneumophila. That's the serogroup 1 is the primary species linked to disease and is the primary one tested by the urine antigen test, or the only one tested. Though there are other methods to test for the disease. And it develops or refers to a lung infection. Or a Legionnaire's disease does, though there's different forms of Legionellosis, but we usually prefer to just say Legionellosis to be more general. So Legionnaire's disease is, and one of the reasons we focus on healthcare facilities and long-term care facilities in general is because of the percent of those there that are higher risk for disease. So this is going to include current or former smokers, cancer patients, or anyone with a compromised immune system, anyone with chronic lung disease, or anyone above the age of 50. Onset of illness, usually 2 to 10 days. The incubation period right now is, that CDC uses is 2 to 14 days, and we'll talk a little bit about case definitions versus healthcare association, which is based on how much of that incubation period is spent at a facility. And Legionnaire's disease has a, I apologize for the capital D, that's unforgivable. I'll just leave if I ever forget to italicize Legionella. Has a mortality rate of around 10%, a bit higher in healthcare facilities, could go up to 25, 30%. Numbers kind of vary depending on the publication. So here is a figure from the age of onset in Ohio that Ellen prepared from 2017 to 2018. As you see, there's a pretty major increase once you hit that 50 range and up in terms of reported cases. Next is just kind of a comparison of the trends in US and Ohio, though the most important thing to kind of focus on, and I apologize, this looked a little bit better on my computer and when I had it in presentation mode. But basically we just start seeing an increase in the early 2000s, but especially once we get into the 2010s in diseases. And we'll talk about a few of the possible reasons that is. It's not all just more people getting sick, or at least that's what is commonly projected. But that is pretty consistent in both Ohio and the United States as a whole. And this is kind of reflected as well. We see a stark increase around 2013, 2012 area and kind of going up till current. We did have a bit of a drop in 2020, though there's a couple reasons for why that might be. Though it is a little bit suspicious when you look at it. So in the nation as a whole, one of the reasons we focus so much on Legionella response and why we get a lot of support from the CDC is because of the number of cases in Ohio. It varies from year to year. We used to say we were first, and then when I got here, I said, that's not true. New York is separating out its city. But we're second, usually, in terms of number of cases each year. Though a lot of states kind of in the Northeast, Pennsylvania, are fairly high, so it can change a little bit from year to year. So in 2020, as I mentioned before, there were other priorities at the time, to say that lightly. So there is 537 cases, but we usually see around 800 a year, at least since about 2017, which is what we saw again in 2021. So a couple of reasons that people look at for why cases of Legionnaire's disease are increasing. Aging population, more use of immune suppressive drugs, a higher prevalence of comorbid conditions, growing dependence on different systems that might expose people, increased complexity of plumbing in large buildings. It's not on here, but kind of aging infrastructure, inadequate maintenance of public water supplies, and it is also thought that there could be increased reporting and increased testing for Legionnaire's disease as well. Month of onset. I do think this is an interesting figure, which is why I included it. We do tend to see more cases in July. However, in terms of full investigations, when we see a presumptive case, doesn't really prefer a month. I pretty much am working on, like, in terms of presumptive cases, me and the other person, Dr. 𝐒𝐿𝐴 Gupta, are usually working on about 20 full investigations at a time, pretty much year round, though it changes. And then a bit more with the non-full investigations, which has a little bit lighter follow-up, and I'll talk a little bit about what's required, though it really varies depending on the scenario for those. But we do see far more cases in the summer. In terms, we already talked about number of cases in states throughout the country. Now in Ohio, it varies heavily from county to county. There's some local health districts I still have never worked with. There are some that I've only worked with once or twice. I often try to see if I can go out and assist them with the response if it's their first time ever working on a Legionnaire's disease, though if it's Columbus or Cleveland, we usually don't. They're pretty familiar with the process. We do see a lot more in Franklin County and Columbus City and Cleveland area. Don't know exactly why that is. There's way less cases in Cincinnati for some reason. But we do find it a bit interesting in terms of kind of the number of investigations. So transitioning a little bit so we can start moving towards the investigations themselves. This figure was already shown once. but this kind of talks about the different places someone could be exposed in a facility. The cooling tower, now my section is going to focus more on potable water systems, but cooling towers are, there's a lot of cases of cooling towers, there's a lot of cases that are linked to hot tubs as well. Due to limited time, I wanted to focus more on the water systems, but no, this kind of applies to all sorts of response. Any unoccupied floor, decorative fountains could still be a risk. The municipal water supply, hot tubs, as I mentioned earlier. There's just any place where somebody could be exposed. Facilities with a high risk. Note that these aren't just healthcare facilities. We've had large outbreaks involving churches. We haven't seen any involving dental equipment, though that's included in CDC recommendations, and I think it would be a possible source of exposure, and part of that might be because somebody spends so little time there, and it might not even be included as part of the investigation interview during the follow-up. Senior living facilities, of course, are one of our main ones, hospitals, though any building with a large complex water system. When I got there in 2018, one of the very first investigations I worked on was a really complex and old hotel that in Cincinnati, and that was like the last time I worked with them until very recently, weirdly enough, because they don't have a lot of investigations. But it really can happen to any type of facility, especially if the water system is complex like that one is. So when we actually, moving on to the investigations themselves and how they form, they start with responding to some form of facility-associated Legionnaire's disease. And first that has to, a case has to be associated with disease. And I haven't even tried to say epidemiological yet. Oh, that was the first time I've got it right on my first try. When we're made aware of a facility-associated case, which happens after the epi interview with the case, ODH reach back out to the local health district, or I reach out to the environmental health side and kind of begin to discuss the next steps, what we expect from the facility, et cetera. And then the local health district will reach out to the facility, gather the basic information, which I'll go into a little bit more detail in a moment. And then, if deemed necessary, a call will be arranged involving the local health district, ODH, and the facility and their consultant if they have one already. Coordination is key. There's a lot of different members here. Not everyone can be at the facility. Not everyone is familiar with the regulations, and we need to make sure that we have a good distribution of information throughout all involved parties for multiple reasons. This will include the facility, any outside consultants, local jurisdiction, the Ohio Department of Health, CDC. It can, if during response we determine that we need longer term treatment, it will involve Ohio EPA, and it can involve any, depending on the location, it can involve others as well. Between January 21 and April 22, we had over 83 investigations with around 35 local health districts. It's kind of a breakdown of our investigations. So we do have a little bit of everything. Apartment buildings, which is a non-healthcare facility, we often have several, and there's not as much regulation in regards to that, so our response has to differ a little bit, but the majority of them still involve long-term care facilities and hospitals. So breaking down the roles of the different parties, starting with the Bureau of Infectious Disease. So they're responsible for case surveillance and disease monitoring, supports epidemiology investigations, and gives training to local health districts. They can request epi aid from CDC, and they're kind of in charge of reporting disease occurrence. Now on to Bureau of Environmental Health and Radiation Protection. Nobody knows why our acronym is BURP. I've asked many times and we're still uncertain. So we're in charge of providing the technical assistance to local health districts when it comes to the investigation itself. Ourselves or the environmental health at the local health districts are usually the two that take the lead once we're actually moved on to building response. So environmental technical assistance, we distribute resources and we'll provide trainings such as this. Now local health, so they're more in charge of the direct response and working directly with the facility, especially after 2020 and COVID response. It's been more difficult for us to go out to facilities, though I still do from time to time if needed. So usually they're the ones who are more familiar with the actual facility staff outside of the calls. So they help us, and they're usually the primary point of contact with the facility, though it can differ from case investigation to case investigation. So those requested materials I listed earlier, depending on what's present at the facility, these can differ, but we always want the water management program first. Then sampling logs for Legionella, if present. Any monitoring logs, this will include temperature, chlorine, pH, just give us any documentation you have on what you monitor, and if you have a cooling tower, include any logs from that and any servicing and disinfectant residual logs. A floor plan of the facility, I'll be extra happy if you mark where the case room is in this investigation for me already, or any indication of how the water system moves, though there should be a flow diagram in the water management program itself. The quality can vary heavily, and the example provided in the CDC toolkit that they're asked to give is very bare bones compared to what Doug showed earlier, which I much prefer what Doug showed earlier. I want an idea of what the facility looks like, especially once we move on to the later steps of the investigation. And anything else, cleaning, disinfection logs with respiratory equipment. We don't usually find things in humidifiers, but any other material. One time we went to a facility and there was a underwater treadmill that was used for rehab, which was kind of interesting. So we needed a lot of information on that, but anything that might come up in the investigation itself. And depending on what material you have, like if you have a very strong water management program and lots of sampling history that can demonstrate that it's not an issue, then the investigation response can be lessened, at least unless it's a presumptive case or there's a lot of cases. So our full investigation procedure. So this is based on a few things. And a few resources. The CDC website has a full investigation response, though there's parts of it that it's kind of vague or wishy-washy on what you're supposed to do. So we talked with CDC and we talked with the director of health, especially around the time of the Grove City, which I'm glad Doug brought that up, that outbreak. And we kind of determined what the full investigation procedure would look like. What determines a full investigation procedure is a single presumptive healthcare associated case or multiple possible cases within a 12-month period. So those terms, they used to be definite before the lot more lukewarm term, presumptive. But basically it's a second set of case definitions beyond confirmed, where that just it determines whether someone has Legionnaire's disease. This is determine whether or not, how likely it is for it to be associated with a particular facility. With presumptive, meaning at least 10 consecutive days at the facility, exposed to that facility's water systems with no outside visits during the 14-day incubation period. And possible meaning basically everything else. So there could be a lot of variation in our response to possible cases. And this is just with healthcare facilities, though in the CDC guidance, they say to basically treat a correctional institution the same way. Because usually people at correctional institutions aren't leaving a whole lot. And I'll go into each step, but first thing, when it's almost certain that a case is at the facility, is to stop any possibility or drastically reduce the possibility of further exposure by implementing immediate use of water use restrictions. Having some form of communications to patients and staff, completion of a facility assessment, sampling for Legionella, addressing any water system concerns such as plumbing corrections, some form of remediation, collecting additional sample sets following the remediation, and then reviewing and revising the water management program before lifting the water use restrictions. And it's a long, intensive process. The length of an investigation, I think the quickest to have, and the facility really had to be moving from the start and already familiar with the response, was probably around 45 days because they needed those 3 sample sets. Though generally, I'd expect it to be closer to the end of the 90-day filter's life. So that's why we generally recommend 90-day filters, though it's not a requirement. That's something you discuss with your consultant. Though it's better to have those in place than have to replace them. And we've seen them last close to half a year. It can really depend on the level of issues at the facility. So before I actually go into the investigation steps, we'll talk about consultants, which I'm sure Solid Balloon will appreciate. So initiating, when we're initiating an investigation, it's much better than having us tell you what to do or having the local health district tell you what to do, because neither of us are going to be really at the facility all the time and really intimately familiar with the water system, the cooling towers, all the other water features, and just spend a lot of time understanding the plumbing, nor do we necessarily always have the expertise to do so. It's much better to have a consultant that is not only familiar with the water system, but also familiar with what's generally expected in this state with Legionella response. And I try to meet with consultants whenever I hear of a new one that's working with a facility that I've never worked with before, and kind of discuss that in detail and kind of our expectations. And if they have a water management program template, I'll review that as well. We do have a list of active consultants, and if you're working as a consultant and you're unaware of this list, we might just not have worked with you in the past. So just contact me and we can arrange a meeting and we'll add you to that list, and we just send it out whenever there's a case. Or moving on to water use restrictions. So the purpose of the water use restrictions is to immediately eliminate risk and give us time to do response. Once the water use restrictions are in place, there's a lot more time to develop a good sampling plan rather than rush out a sampling plan that's not complete and doesn't represent the entire facility. Because when that happens, we'll just end up asking the facility to sample again with an expanded sampling plan. If there's a lot of areas, or at least add those sampling locations. So Water use restrictions can mean multiple things, though especially for a hospital, it's preferred for that to mean filters. There are issues with the supply chain and getting filters in right now, and it takes a little bit more time, and we understand that. When filters are placed in place, we mean the entire water loop of exposure. Legionella is capable of moving through the water system. That's how it would have gotten there. So as long as that loop has any unfiltered locations or locations that don't have water access cut off, which is the other option, there's still a risk of exposure. So the options are filters, cutting off water access, or a hybrid of the two, which would be filters in, and this works a little bit better in long-term care facilities than a hospital, but filters in key locations, and then having specific designated areas to like shower, hand washing, etc. So when it comes to implementing water use restrictions, we talked a little bit about how, and I'll talk a little bit about it in the next slide as well, how a lot more Legionnaire's disease is being reported or on the news, or at least when it comes to being associated with the facility. And the water use restrictions are a big part of that. Once people's waters get cut off, especially if they don't want to install filters and just people can't access water at all and have to use bottled water for hand washing, it gets on the news pretty quick and people start complaining. This is a big part for it. So ensuring that staff is properly informed on why these filters are in place and what to do if a filter is damaged, and making sure that there's signage posted on who to contact if that happens. And there's also, you can find additional information on water use restrictions and those recommendations on the CDC website when it comes to outbreak response. Those are kind of the examples of the filters. I didn't actually talk about their specifications, 0.2 microns. CDC provides more details, the FDA approved, there's a whole list. There's a couple of companies that make them that are particularly prevalent, but I think there's more and more that are developing them lately. Though the consultant usually has access to these and is able to get these in. I know Solid Blend, you often have several on hand to respond more immediately. So communications. So CDC mentioned some form of communication about the ongoing Legionella investigation. This is also what often leads to news coverage. So communication should be provided to the following: patients, families, visitors, staff. There are pieces of communication guidance on the CDC website, templates on what to send to staff members at a hospital, materials like that. Next is the environmental assessment. Doug mentioned earlier the LEAF assessment. That's what's on the CDC website. It doesn't actually have to be that. I think that I've seen several assessments that consultants or other companies have had that are a lot more detailed. Those are fine. The purpose of the assessment section is to identify areas of risk that might not have, at that moment in time, compared to the water management program, which is kind of when that water management program is developed, and to make more informed decisions on what needs to be corrected in terms of plumbing and what needs to be remediated. The CDC form, of course, is on its website, though if a consultant has their own form and you're working with them, feel free to use that. I've provided a couple of screenshots of the Legionella assessment form. This is the one, if you already have it saved on your computer, they update it every like 2 years or so. So I believe the latest one was 21. 23. Oh, 23. Yeah, there's a new one. And of course, I took screenshots from the 2019 one. So don't do that. Try to have a more recent version. So just it provides background information on the facility, where they get their water from, the different buildings involved, and helps you break down where the water loops are, though the water management program should do that as well. Not every facility has an effective water management program. So this is often very helpful as a reference to start an investigation. That can be off-put by a detailed water management program. And this section, I always bring this up because for some reason people always leave it blank. If you're doing an assessment, I know it takes a little bit extra time, but it's really helpful to know what temperatures you're getting right now and at what fixtures, and so and what chlorine level you're getting, especially when it comes to the hot water. And a few years ago, with our grant from the CDC, we did send out assessment kits to a lot of not every local health district, but most that get multiple cases in a year and have multiple investigations in a year, which includes a chlorine kit. So they have the capability to assist with that as well. So pre-remediation sampling. This should follow CDC guidance. And because Doug talked about it earlier, I'll go in a little bit more detail. The guidance by CDC has changed slightly, but when it comes to when there's already a case, we don't want any further sickness, but we also like to see as little Legionella detections as possible. Any species, once there's a case involved, we want to, and we usually can, reduce it to as long as it's below 1 CFU. So that was the kind of change in what they were saying rather than 0 all around. Now, once the full investigation is started, even if there's no detections in the pre-remediation, we're still going to go through the whole process with very few exceptions. Samples are ultimately representative, and it's a single sample set. It's not uncommon for us to get no detections. Then they'll remediate and then have a detection afterwards. Usually it's because they do lighter remediation. But that's kind of the result of using a representative sample set, though of course it's very difficult to sample the entire volume of a water system constantly. We'd like to send that to a CDC, a LEED certified lab, using the isoculture method. There's a lot of other testing methods, some that labs will use, but when it comes to an investigation, CDC says have the elite certification. So send a lab to the elite certification, use the method they recommend. You can use other as well. PCR is a lot quicker and allows more immediate response. And if you want to do that alongside the others, that's fine. That helps us respond quicker, but it'll also detect dead bacteria since it's just a DNA test and not a culture. And finally, please send over the water sampling plans to the local health district ODH prior to sampling collection. It should follow the guidance provided on the CDC website for investigation response, which is usually 1 liter bottles. A combination of swab or first draw either can be used, and flush samples, though I much prefer the swab and first draw, so just a couple of flush samples is fine. Once you send all that over, we prefer hot water, though we'd want a couple of cold water samples as well, and and ice machines and any other possible source of exposure. Once that initial sample set has been collected, that's when we start moving towards corrections and remediation. So the assessment, your consultant might have identified a few dead-end legs that need removed or other corrections that should be made. And it's important to do that before you do some form of remediation, because that will make it more difficult for the chlorine or whatever you're using to circulate. Once that's complete, the facility should send over a remediation plan. There's a lot of different ways to remediate. When it comes to case response, we determine by the level of Legionella after remediation, and that's kind of what determines when the investigation can end. So what you decide with your consultant is ultimately a discussion between the two of you. Everything has different strengths and weaknesses. We don't see a lot of success with superheating if you have a lot of Legionella. So we generally don't recommend that, but it's ultimately your decision. If you keep getting detections, then we're going to keep asking for more samples. But that's kind of, people usually like to wait until they get that pre-remediation sample set in before deciding on the best remediation method. And that's a big part of the reason why. If you're not getting a lot of detections, you don't need a strong response. If you're getting a lot of detections and you think that it's going to be very prevalent, shock chlorination probably won't cut it. Maybe monochloramine, chlorine dioxide, something more aggressive or long-lasting. And the purpose of this is to immediately reduce risk. This is not a fix for the system. The most important step is the water management program. And that's a part of this response as well, though the purpose of the investigation response is to get things under control and give time to develop and improve the water management program to control it on a daily basis moving forward. And as I mentioned before, if it's not a full investigation response, we'll ask for less and less of this. The first thing we remove, if it's not full investigation, we only ask for water use restrictions from the start if it's a full investigation. If there's presumptive case or 2 possible cases within a 12-month period. Though sometimes we won't count multiple possible cases if it's just a single outpatient visit. It really depends. That's a little bit more flexible and is kind of a discussion between the EPIs. When it comes to post-remediation samples, which is another item that we might not ask for 2 consecutive if it's not full investigation. They need to be in the same locations as the previous sample set, which is why we approved of the plan. And then we ask for 2 additional consecutive sets of negative samples prior to the lifting of water use restrictions below 1 CFU. There can be some flexibility in the long run if it's a larger issue, that's kind of a discussion between leadership. Next is the water management program. At the start of the investigation, I asked for it, and then I'll review it depending on how many I'm reviewing at that time, or Dr. Gupta is reviewing at that time. It might take a little bit more time to complete. This is where I get all my feelings out, so I apologize. I review for those, primarily for those 7 key elements with a lot of focus. If you want to know what I tend to see a lot, it's going to be focusing on, while the water management program team is important and required, I like to focus on what they're doing at all areas of risk. Having clear control limits, because there's not a lot of point to identifying and monitoring unless you have a control limit, and then specifying the corrective action at that control limit. Now, it was mentioned earlier, sampling isn't required, but validation is required, showing that your program is effective, and in ASHRAE guidance, it really only mentions sampling as a method of doing that. So we generally recommend sampling. It's probably the best way to determine if your water management program is reducing the prevalence of Legionella on a day-to-day basis. So depends on the facility, maybe annual work. Usually like to see twice a year, but that really depends, and is why water management programs should be pretty facility specific. There's a lot of water management program resources. consultants have templates and that ODH is often reviewed. But there's also the CDC toolkit. There's the Prevent LD training, which I think is just a good resource for people who aren't familiar with Legionnaire's disease and Legionnaire's prevention. It's not going to tell you everything, but it's 3 to 5 hour training that will kind of give you the basics and also offers some resources that can be plugged into a water management program. And then a few years ago, sorry for hesitating, it's because I hate saying this organization's full name because I'll stutter. The Council for State and Territorial Epidemiologists, CSTE, thank you. They developed a water management program template several years ago. It's very exhaustive, but I've seen facilities make decent water management programs taking what is needed from that. It kind of includes all steps and all scenarios in their template, and that is on their website. So as I mentioned before, they need to be tailored to the building. A lot of networks and corporations that have multiple facilities will make their general template, but they still need to have, obviously, the flow diagram, the water management program, that should include people at that facility. And even their monitoring should be more specific to the features at that facility. But you can certainly have like a broader one that you can tailor more specifically. We've found, after reviewing this, and I'm going through a lot of our older water management programs right now to kind of evaluate them that we've received, they're missing key components. Sometimes they're just a page of copy and pasted info from the CDC website. Sometimes there's a little bit more, but they'll leave out generally a lot of the most important information. Sometimes it'll be 20 pages of backgrounds of Legionnaire's disease with no helpful information. And coming from years working in more focused in academia, though I was focused on mushrooms, I never expected to work with Legionnaire's disease. Not that type of mushrooms. Just clarifying. Ecological distribution of fungal fruiting bodies. There we go. Working on a lot of that, I don't have a lot of patience for a lot of the fluff and unnecessary information. Ultimately, the water management program is a tool for the facility, and anyone at that facility should be able to look at it and not have to read 20 pages about Legionella and just know more detail about the water system, what they're doing on a day-to-day basis, especially because there's a lot of new hires always coming in. There's facilities I've worked with 3 investigations with 3 entirely different staffs in just the 5 years since I've been here. So it's important to have information so somebody could come in and know what the maintenance is supposed to do if there's a new maintenance supervisor. Finally, lifting water use restrictions. So once all those requirements are met, the water management program could take a little bit more time as long as the Legionella issues are under control and as long as they're working on it and have agreed to make changes. That's when the water restrictions are lifted. And we ask that they work with their consultant to flush or do anything else needed to adjust for flow changes. So continuing monitoring, this doesn't happen often, but we do often ask this for hospitals with a lot of Legionella detections that had multiple cases. We ask that they continue sampling based on HICPAC guidance. We've adjusted it because it says 6 months and to monthly for 3 months, just to kind of get an idea that things are being reduced. If they get detections during this time period, they should follow their water management program's guidance on how to respond and not the investigation guidance. They don't need to put filters back in place unless there's another case. And that's kind of the contact information. I included Ellen. It's not kind of, it is the contact information. I included Ellen as well, who prepared the epi side and a lot of that past case data and the figures in the earlier slides.
Thank you, Bryce. So I've got a couple trivia questions for you all from Bryce Kerr. And I don't know if I know how to use this. Big green button. What types of case or cases cause Ohio Department of Health to initiate a full investigation? He's not giving you true or false today, folks. Single, presumptive, or too probable is the response. I have the answers. It's, would you qualify that as a yes? He'll allow it. So the official correct is one presumptive healthcare associated case or multiple possible healthcare associated cases within 12 months. So multiple within 12 months or one presumptive. Question number 2. In what year did the state of Ohio have the most reported cases of Legionellosis? Anybody? Got one right here? 2019 is correct. Beautiful. Thank you. Last question. I'm getting ready to give you guys a break here. Bear with me. What are the 3 main parties involved in a Legionellosis investigation? That is correct. Thank you. All right, so we had breaks scheduled from 10:30 to 10:45. I think we've got a little bit of leeway with the length of time we dedicated to the panel at the end of the day, so I'm going to give you a full 15. So at 10:50, we'll kick off with Janet Stout, and I will introduce her. Thank you all. Again, vendors are in the back. Good time to maybe check in with them. A good time to check your emails, visit with some folks you haven't met yet. Thank you all. Those of you up and moving around, I appreciate that. We are going to go ahead and get started to keep the schedule moving in the right direction. I'm sure you all want to eat lunch on time. I know I do. So for those of you who are in the room, if you could please tone it down just a hair, I would appreciate it so we can get Dr. Stout up here and let her kick off her presentation. So up next, we have Dr. Janet Stout. Dr. Stout is the Executive Vice President and founder of Special Pathogens Laboratory, a PACE Laboratory and Research Associate Professor at the University of Pittsburgh in Swanson School of Engineering and the Department of Civil and Environmental Engineering. I was just talking to Dr. Stout. I think her and I have now officially known each other for over a decade, and it's been a lot of fun working with her. She is a huge advocate of prevention. Dr. Stout assisted in developing the first Legionella prevention guideline in 1993 in the United States, which continues to serve as a model for national and global health agencies and organizations. Additionally, she serves on the ASHRAE Legionella Standard Committee for Legionella Guideline 12, as well as the 188 Committee for the ANSI ASHRAE Standard 188. This list continues to go on and on. She asked me to keep it short and sweet, so that was from her. So without further ado, I would like to welcome Dr. Janet Stout.
Thank you so much for being here. That was kind of fun, right? So 10 points for whoever can tell me who was singing that song. Yes, Thomas Dolby. So first of all, I wanted to say thank you to Solid Blend for bringing us all together. I want to say hi to our virtual attendees. We're very appreciative that you're with us. And just a quick sort of take on the room. How many from public health? Woohoo! All right. How many infection preventionists? Nice. Facilities, engineers, thank you for being here. So, you're probably like, what is she going to talk about? So let's sort of get to it real quick here. Just real quick acknowledgement of Special Pathogens Laboratory, a PACE laboratory now. One of the things I sort of created as a tagline for us is that we're more than a lab. So not only do we do Legionella detection, but we also do prevention and consultation and education, which is really my passion. And you heard I do sort of wear a research hat with the University of Pittsburgh Civil and Environmental Engineering. So I always say I'm a microbiologist with a minor in plumbing because of my affiliation there. So you sort of notice the pin. You might have noticed the pin. So the pin's on my picture there. So does anybody know what a BHAG is? It's not unusual for people not to know. It's not a disease, so that's good. It's a big, hairy, audacious goal. So the big, hairy, audacious goal for us is to end Legionnaire's disease. Now, just to show you how serious I am about ending Legionnaire's disease, not only do I have the pin, but if you look very closely, I have matching earrings. And ready for this, I don't know, I can't get my leg very high. I also have matching shoes, NLD shoes. Now you won't find these at your famous footwear, but for us, it just sort of goes to the mission of ending Legionnaire's disease. So that's what I'm here to sort of talk about. So I'm trained as a public health infectious disease microbiologist. So I went to the University of Pittsburgh Public Health School. And what I say about being a microbiologist is that and I cut it off at 30 years, okay? I just refuse to say how many years it really is, right? So after 30 years of being a microbiologist, studying Legionella, I say I'm not a microbiologist anymore, I'm a Legionellologist. Yes, I did make that up, but it adequately describes my career. So my goal here is to really share the mission and the knowledge that I've learned in those more than 30 years. And I told Steve, I'm not old, I'm experienced. And please feel free to use that if any of you are over 50 years of age. So on the subject of our mission, it's for many, many years, it was just Legionella that I was talking about. But the mission has expanded, and rightly so, to include not only Legionella, but other waterborne pathogens. And can you tell I'm passionate about what I do? I'm passionate about proactive prevention. And that's what we're here today to talk about, is not waiting until we need Bryce or our public health people. We want, no offense, we don't want you to come. We want you to say, yay, way to go. You're doing a great job, because we're not coming to your facility. So that's what all of this is really about. So I want you to think about me as your microbiology tour guide today. And I want you to sort of think a little bit like a microbe. Okay, you don't have any problem with that, right? So we're going to sort of talk about building water systems from the perspective of the microbes that are in them. And I'm going to explain a little bit about the microbiology. Now, before you think snooze button, right, I'm going to make it fun. I always thought microbiology was the greatest topic in school. And I said, microbiology is fun if you just know how to think about it, right? So most of you are going, well, we'll see about that. So how should we think about the bacteria that are in our water? So a lot of what we're talking about is kind of scary. It's like, oh, those bacteria are really dangerous. So this is the reason for my topic and my title slide. Are they marauders or are they microbiome? And so at the dinner table tonight, you can impress your kids by saying, I went to a conference today and we talked about the microbiome. And then you say, do you know what that is? And they're going to go, no. Well, I can tell you what it is. So let's start with the marauders. So this is a funny image of sort of the attackers ready to go into the city and attack, invade. They're relentless and invasive. And certainly, if it's a microbial marauder, we want to be a little worried about them, right? So we're going to talk about that. But the microbiome, actually, it's kind of a nice sounding word, isn't it? And when I started in microbiology, we weren't talking about microbiome. So in the 30 plus years I've been around, we have new vocabulary. So now I'm sharing my vocabulary with you. So what is it exactly? What do I mean by microbiome? And it's really the community, it's a good day when I can say the word consortium. It's a group of organisms that are living together in whatever environment that would be, right? And so we're talking about the environment of water, mostly. But just to put it into context for you, we also talk about the microbiome of the human body. And you might have read a few things about the microbiome of the human body. And so it's kind of a creepy statistic, actually. For every cell in your body, there's an equal number of bacteria or other organisms on or in your body. And that translates to trillions, 10 to 100 trillion microbial cells. Now, more specifically, on your skin, the microbiome is composed of over 1,000 different members of microbial populations and trillions in your gut. So we don't get, although it's not really fun to think about all these bacteria on us, in us, we don't freak out about it, right? We just know they're there, mostly helpful, right? So the bacteria in our water systems are also similar in this regard. Most of the time, completely harmless, but sometimes they can cause problems, right? So we're going to be talking about the microbiome. I gave you the example of our microbiome. And then in the case of our plumbing, we talk about the slime layer that's inside all of our pipes and fixtures, or the official scientific term is the biofilm. So we have our pipes, and then we have our building water distribution systems. So you start seeing the term microbiome in association with plumbing. And this article is an example of that. So feeding the building plumbing microbiome, right? And the stuff that we have, the pipes and the pieces and parts in our building water systems are part of that microbiome. And the topic of this review paper is how they contribute nutritionally, like they secrete carbon and things like that that help microorganisms grow, or they provide surface area that allows them to grow. Now, we touched a little bit about sort of why is it that certain parts of Ohio have more cases, or why is it the North Atlantic region has more cases? And it really starts at the source water. Surface water seems, as source water for our buildings, seems to be more prone to that building having Legionella in it. The reason is that's a naturally occurring place for Legionella and some of the other organisms we're going to talk about in a minute, like non-tuberculous mycobacteria, Pseudomonas aeruginosa. These are soil and water organisms that are naturally found in our source water. What happens as we go from left to right is that that community changes because the conditions in treatment at our municipality, and then in the distribution, and then in our building water systems, those conditions are different. So for example, when that river water goes to the treatment plant and they apply chlorine, it changes the proportions of different populations of bacteria. It selects for the ones that are more chlorine resistant. Who is that? Legionella, non-tuberculous mycobacteria. So we are improving the quality of water by getting rid of things like Shigella, Salmonella, the ones that cause diarrheal diseases, but we are inadvertently helping certain organisms come through the treatment into distribution at a higher percentage. So this is a normal process, now that you're thinking like a microbe. So let's make you a Legionella microbe. I can survive chlorine treatment at the municipal plant. So I'm a superbug, right? And then the conditions change again in the plumbing distribution system. We get this is from the source to the treatment to distribution, that's cold water. So now in distribution, you have miles and miles of pipe. And whatever disinfectant was in the source water starts to go down, right? And so you are Legionella, you are chlorine tolerant, more resistant to chlorine at the levels that we use to treat our water. Now you go into distribution and we start to get conditions like stagnation, soil coming into the distribution lines, things like that. And then finally, in our building water systems, the biggest difference is warm water. So this is why I worry more about the hot water distribution system, because now we've added to the existing nutrients, the existing other microbes, elevated temperature. It's like a spa for the bacteria. It's like fantastic, I'm in that whirlpool spa, which I will talk about in a minute. So now the conditions are really ripe for our microorganisms. So from that paper, it talked about materials, plumbing materials. I just wanted to give a couple examples. The table there is just for a list. When I started, it was really just copper piping. But over the years now, it's all kinds of different types of plastic pipe. And I can tell you that some of the carbon that comes off of plastic pipe, certain bacteria like Pseudomonas that can survive in low nutrient environments are like, yeah, I love this plastic pipe. So now we've got plastic pipe, metal pipe, and really complex fixtures, and this is a blow-up of that. So the bottom two pictures are one fixture, and all the pieces and parts that are part of that single fixture. So now you're thinking plastics, different types, huge amount of surface area. They're so much more complex than they used to be. So lots of opportunity for that biofilm and microbiome to form in our fixtures. So it's an impressive amount of material in our fixtures. People ask, should we have an aerator? Should we have a laminar flow device? What's better? Well, the only thing I can tell you in studies that we did and others is that when I took apart a laminar flow fixture, it had lots of pieces and parts. A standard dual handle fixture has a fraction of the number of pieces and parts. And then if we looked at fixtures that had aerators or didn't have aerators, there was no difference with Legionella, but the laminar flow device and the aerator had more total bacteria. So no difference for Legionella, but just remember the complexity of the fixtures that you select, and this goes to construction, pre-construction design. You want to be thinking about that because now you're thinking like a microbe, right? Now you're thinking like Legionella. So speaking of Legionella and what makes us grow, so in this group of bacteria, which one's Legionella? I'll give you a hint, it's the cool one. So it's the one with the sunglasses, right? So Legionella is the cool one. So what makes us grow? So when we were talking earlier, I think Doug mentioned water age. So now that you're thinking like a microbe, why would water being in the building, in the piping, longer be an advantage to you? So that's what I want you to think about, right? So whatever disinfectant was there, it's gone, right? It's not there. Now just remember that the amount of disinfectant that comes into the building is not enough to control Legionella, especially in hot water. Okay, so, but it's nice to improve overall hygiene. The temperature. So if it's cold water, if it lays in there and the water age goes up, the amount of time it's in the pipe, cold water warms up. Hot water gets cooler. So now the water starts to get into the sweet spot for Legionella to grow, right? So having that water in there longer equilibrates to growth-promoting zones. What happens to the overall numbers of bacteria in that water? It goes up. It goes up because the temperature is equilibrating into the sweet spot, and it's sort of standing there without flow. Those bacteria help Legionella to grow. So there's a relationship between all these bacteria. It's like, you're my friend, you're gonna help me grow. And so when all the bacteria start to replicate, it can help Legionella to grow by providing nutrients. So that's called synergy. So that's another thing you can say at the dinner table. You know, we're talking at this conference today about the consortium of microorganisms and how they work synergistically. And you're gonna like, okay, if you have little ones, we're gonna learn how to spell synergy. And so they work together. And then when all of that is happening, you may need to do supplemental disinfection. So it got me to thinking about how can I visually demonstrate this concept of what happens when water doesn't flow. And this reminds me of Tina Turner. What's flow got to do with it? Got to do? Okay, so microbiologists are not good singers. So this is the experiment I did, and I want you to use your imagination, okay? Ready? Think of the vase as the pipe. Think of the flowers as the nutrients that are in our pipe. And when there's no flow, what happens? So in this vase, I let the water flow continuously. And then in the other vase, I didn't. I turned the water off and I just let them sit there at room temperature. And that's what happened in 2 to 3 days in that pipe with nutrients. Now, we're really gonna work on the ick factor here, and so we're gonna get a little closer. Now I want you to think about that picture when you think about water stagnating in your pipes, or that time between construction and handoff when nothing's happening in that pipe that has water in it. So what's in your stagnant pipes? I put Mr. Yuck there because even me, when I look at it, I'm like, ugh. So what's happening in your pipes, right? It's a party in the pipes. These bacteria are having a party in the pipes. So just imagine tiny little party hats on our microbes, right? They're going, this is fabulous. I love this. I got my friend. I got nice warm temperature. I'm going to have a party in the pipes. So remember, for a long time, we were focused on Legionella. So who's at the party now? Well, it's not just Legionella. It's Stenotrophomonas multifilia, Acinetobacter, Pseudomonas, amoeba-resistant bacteria. This is, so as if you're not disgusted enough, we also have unicellular organisms called protozoa in our water. You probably drink a whole bunch of protozoa every day and you don't know it. But they're harmless for the most part, but they are a vehicle to allow Legionella and non-tuberculous mycobacteria to grow inside them. I think we're starting to think about a sci-fi kind of program we could like on Netflix, right? So Stenotrophomonas multifilia. So I want you to remember that, Stenotrophomonas multifilia. I feel like I should do a line dance, you know, kick. Now, I'm going to share with you some results from the laboratory that shocked me. Takes a lot to shock me, right? So when I looked at these two plates, and you're all like going, am I going to get tested on this? What is Klebsiella? No. But when I look at this and these bacteria growing on this plate, I'm thinking, oh, that must be like a urinary tract infection culture or a wound culture, because I don't see these organisms normally in water, right? I hope you're going, what? Now that's disgusting and alarming. So that's what was in the water coming out of the fixture of a medical intensive care unit. So you're washing, the caregivers are washing their hands in Klebsiella and Pseudomonas. Let the water flow a while before you use that water. So why do we care about these organisms? Because I always like to ask why. When I was like little, my mother told me, I didn't ask why, I said, how come? Over and over again, how come? Drove her nuts. But I think knowing the why is important. So Doug touched upon this. The Center for Medicare and Medicaid Services came out in 2017 with their Legionella memo, but to my surprise, they just sort of lobbed in there other opportunistic waterborne pathogens. I was like, what? Okay, that's interesting. And it was their acknowledgement that these organisms are important in causing healthcare-associated infections. So kind of while we're at it, talking about Legionella, let's also raise people's awareness and requirements around risk assessment of other waterborne pathogens. So not only do you have the risk assessment for Legionella, CMS and the Joint Commission say you have to assess the risk of these other opportunistic waterborne pathogens in your water as well. So that's important for you to know. And there's that list. This is from the CMS memo. Our Stenotrophomonas, Acinetobacter, Burkholderia, all these words that you're just going to say, waterborne pathogens. Isn't that so much easier? Waterborne pathogens. We don't have to know the bacterial names. The Joint Commission came out after CMS, basically saying, as Doug said, we had some environment of care standard around really utility water systems. And what I was so disappointed about the Joint Commission is that the old environment of care standard didn't even say the word Legionella. Like, what is this? It's like code. So now they're actually saying Legionella and waterborne pathogens. They warned us in March of 2021. Then they told all these different facilities that we're going to now start requiring this. And it is based on CMS, CDC, and ASHRAE. Don't you love acronyms? I was so glad when ASHRAE started to go by ASHRAE instead of the American Society for Heating, Refrigeration, and Air Conditioning Engineers. Thank you for that acronym. So all of the elements, those of you that understand ASHRAE Standard 188, are listed there by the Joint Commission. The additions, like CMS, is waterborne pathogens. So ASHRAE 188 is a Legionella, minimizing the risk of Legionella in building water systems. Remember, it's not eliminating. Our goal is to minimize. You can't eliminate. Not only can't you eliminate the organism completely, not in my entire lifetime of study have I ever seen that, even with supplemental disinfection, but you can mitigate the risk by lowering how much is there. So my analogy, it's the pot on the stove with the lid. So your supplemental disinfection is the lid on the pot. Your water management is the lid on the pot, controlling, minimizing the risk, not eliminating it. So it's always important to manage expectations. We don't want to say to facilities, I want you to get rid of every Legionella bacteria in the whole place. Because they're going to say, I can't. Or maybe they give their best effort, but then there'll be positives, a few, and don't blame them. Don't blame the water treater. It's an unrealistic expectation based on the biology, the microbiome of water distribution systems. I like to talk about this. Who's on the team? Infection control needs to be on the team. When we did a survey of people with water management plans that we had worked with that had outbreaks or cases, and we asked, how many of you have infection prevention on your team? It was like 53%. But when we asked how many have facilities on their team, it was 98%. And we presented that information at the National Infection Prevention Conference to say that infection prevention is key to a healthcare water management team. Why is that? remember, the first step is assessing risk. You have to know who in your facility, what patients are at greatest risk. Who knows that? Infection prevention knows that. So they work hand in glove with facilities to identify where the sampling needs to take place, who's at greatest risk, and it's really important for them to be there. I like to have the plumber. So all my career, I was locking arms with the plumber. My first plumber was Lou the plumber at the Pittsburgh VA Medical Center. He's the guy that had the Sawzall, who cut into the pipes of the sink so I could tell how much Legionella was in the hot water and how much was in the cold by not waiting for it to commingle at the fixture, but by getting it at the supply lines. And I can tell you, orders of magnitude higher in the hot, a little bit on occasion in the cold. So this is why I worry most about the hot water system as a reservoir for Legionella. So important to have infection prevention there. Doug talked about the flow diagrams and specialty water systems. So specialty water systems, we get a lot of questions on dialysis and other water systems. So that's also part of the discussion. So environment of care, elements of performance. These are the new numbers for a Joint Commission. EC 0.2, 0.05, we're going to quiz you on that number later. No, just kidding, just kidding. So those new requirements went into effect January 1 of 2022. So at first, the surveyors were not really asking too much about it, but 1 year later, they are. And so you need to be ready for those questions. And the surveyors, whether it's CMS or Joint Commission, want to know, you have the plan, you have all the elements, and Doug mentioned this, what is the documentation of your execution of the plan? Everybody falls down with implementation and execution of water management plans. And so that piece of monitoring, is it in your control limits or out? If it's out, what did you do about it? What was the corrective action? And did you document this and then correct it and then test it again to show that now you're back inside your control limits? That whole process has to be written down somewhere. And that's what you need when the surveyors come. You may not know about this. This is the next ASHRAE standard, proposed standard 514. It is out for public review, likely the last public review right now, which ends April 3rd. What you need to know about this is that it's a risk management for building water systems, physical, chemical, and microbial hazards. So ASHRAE is expanding beyond Legionella into these other areas, including other waterborne pathogens. So coming attractions, I predict it's likely to be the last public review. If you're interested, you can go to ashrae.org, search for 514 and read it. You have to be really dedicated. Read it and comment on it. So there's a section for healthcare, and the infection preventionists should be very interested in what they're saying on these other waterborne pathogens. The chemical is supplemental disinfection. So there's a section on there that the facilities and the consultants need to be paying attention to. And then the microbial hazards are important. The physical is just temperature. And one of my comments was just say temperature, because there's no other physical hazard talked about in 514, but they did not accept my suggestion. So important to know. So why do they care about these waterborne pathogens? Wow, I'm like, okay. Because they cause infections in healthcare facilities, mostly. And mostly in people who are not well, right? That's why they're in the facility to begin with. And many of these bacteria that I've talked about are resistant to the treatment that normally you would get if you had, say, a wound infection or respiratory infection caused by these organisms. So antibiotic resistance is something we really have to be afraid of. And there's all in the news about Candida auris, made the local news. I was like, wow, there's infectious disease on Channel 11. That's so cool. So what do I say about these organisms? I say they are X-bugs, right? They are resistant to these organisms, or to these antibiotics. And it's the whole group of organisms that CMS listed there in Joint Commission. So the X-Men apocalypse were X-Men. So CDC decided that they needed to put some dollar figures to the impact of these infections on the healthcare system. So this is in emerging infectious diseases. It's free, and this is in January 2021. So just to give you some shocking numbers, lots and lots of infections due to these waterborne pathogens, many deaths, billions in healthcare costs. And what was really dramatic to me is that 72% of that cost was due to Legionella, Pseudomonas, and non-tuberculous mycobacteria. So it's costing us money to not control these infections. And so that's important to know. And then in terms of other CDC publications, this one in Infection Control and Hospital Epidemiology in 2019 talked about CDC investigations of outbreaks due to waterborne pathogens other than Legionella. Where are they happening? What organisms are responsible for those infections? And so mostly inpatient facilities, but what was notable to me was that it was also long-term care and outpatient facilities. So we can't ignore them in terms of the cost and impact on morbidity and mortality. And then which organisms were responsible for the majority of CDC outbreak investigations? And many of you probably were like, non-tuberculous mycobacteria, what is that? But this is a water organism. Most of them, of these CDC consultations were that, Pseudomonas and Burkholderia. So I'm just gonna take a minute to talk about Pseudomonas aeruginosa. And what do we know about it? It's the most common waterborne pathogens, antibiotic resistant. It causes interesting infections, folliculitis, which is skin, and ecthyma gangrenosum. I'm not going to ask you to say that, not even you, Bryce. So what is that, right? So everybody likes hot tubs. And so would I get in a hot tub? No. But it's fun until that happens. So that's when Pseudomonas is not well controlled. It's folliculitis. Now, this is the reason they didn't put me on first this morning, because this is really disgusting. This is the serious wound infection that I talked about caused by Pseudomonas, mostly in the immunocompromised. So you don't want that to happen, certainly. And then no babies get waterborne infections, right, Morgan? No babies. So Pseudomonas causes infections in neonatal intensive care unit. Notice the faucet type, electronic sensor faucets, more complex pieces and parts. For years have been associated, going back to 2001 is the first publication I saw, more Pseudomonas and Legionella in electronic faucets than individual manual faucets. In Pennsylvania, NICU babies got Pseudomonas infection, not from the water distribution system, but because of the way they were cleaning the formula bottles. The water that was used and it caused deaths. Pseudomonas aeruginosa in premise plumbing of large buildings. So Pseudomonas is there, soil bacteria can cause infection just like Legionella. Oh, I put free. Microbiology Open is the journal. Sort of like Emerging Infectious Diseases, these are free publications. If you want more information, we do something called the Wednesday, Puzzled by Legionella Wednesday webinar series. Olga Gutzman did a publication on Pseudomonas in the NICU. If you go to our website, specialpathogenslab.com, and look at resources and education, you can listen to the archived presentation. So things that she recommended, and this is construction related, right? You should have faucet design that reduces materials that promote growth, that reduce stagnation, right? And minimum surface area. So I'm not saying you can't use electronic faucets, but maybe you don't use them in the NICU or the bone marrow transplant unit. And factors promoting development of Pseudomonas, temperature, dead legs should be avoided. So we've talked now about the marauder. So the microbial marauder the bacteria become marauders because of the people that that are exposed to them, their antibiotic resistance. They can cause serious infections. But I'm a glass half full person, right? We can stop them. Anybody a fan of Guardians of the Galaxy? I can watch those movies over and over again, right? We can defeat them. So what do? How do we detect them? Water management. These are the things that you need to know about. How do we identify the risk of these pathogens without testing? Can't. You need to develop a sampling plan to understand these pathogens and where they might be and the risk. So here's a nuanced message for you. So people in healthcare know that they are detecting these organisms in their patients, Pseudomonas, non-tuberculous mycobacteria, Acinetobacter, Burkholderia. But the media that they use on people to inhibit the microbiome of us is great, but those inhibitors, the bacteria in the environment are doing this. They won't inhibit them. So special media are necessary to grow Stenotrophomonas, Pseudomonas, Acinetobacter, Burkholderia. Special formulations designed to inhibit environmental organisms are necessary. So if your clinical lab says, we can take your environmental samples and look for these organisms, and then they tell you we haven't found any, you need to ask, were the plates overgrown? Because that's going to be a yes. Because they don't have a specialized laboratory media for isolation. So it's beyond the hospital laboratory for those reasons. So if they're doing it for you, you may not understand the risk, right? Here's an example. So this culture media is typically used in a clinical microbiology laboratory. It is covered by bacteria that are not non-tuberculous mycobacteria. We use a special media called RGM. Those are non-tuberculous mycobacteria, and it completely inhibited the background organisms. So that's just a visual example of what I'm talking about. So we've talked a little bit about the CDC toolkit. I was so happy. What makes a Legionellologist happy? In January of 2021, for the first time ever, the following words came out of the CDC's mouth. Routine monitoring for Legionella. Before then, they would not comment. They would say, we don't have enough data, blah, 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 to talk about routine monitoring. So they finally did talk about it. They talk about, their toolkit is supported by CMS. They updated it for Joint Commission because Joint Commission just came out, and ASHRAE, of course. Lots of great information about controlling Legionella in various places. Of course, our main focus is in the water distribution system. Now, I'm sort of teeing up Dave here. So implement control measures. No single control measure ensures control, even if it's supplemental disinfection. So there's lots of things that affect the efficacy of the disinfectant that you add extra. Includes flow, right? If you don't get the disinfectant through the fixture, you're not going to protect the user of that fixture. So this is why Doug was talking about the need to move water, especially if that water has supplemental disinfectant in it. You got to get it through the system. So you could have supplemental disinfection, but the other control measure is moving the water, flushing the water. Flushing water by itself does nothing except temporarily reduce Legionella and the pathogens in the fixture. What do I mean by that? The first water through the fixture washes off the loosely adherent bacteria from the biofilm. And so now I'm going to do the biofilm dance. So I'm attached. The water comes and I'm flowing down the drain. But I'm not gone from the fixture, just my loosely adherent brethren are down the drain. The other ones are stuck on there real tight until the next time. So don't kid yourself that flushing is going to control it. Anybody a fan of The Last of Us? Oh my God, I'm so sad it's over, but only temporarily. So I put this, it's a patient safety issue. This is where facilities and infection prevention and public health come together to protect patients, not from a deadly fungus, although fungi are listed by CMS, but by these pathogens. We need a higher level of water quality in healthcare, right? Because we know now the dangers of the organisms in there. There's water everywhere in healthcare. It's used through the whole healthcare continuum of care, but it's necessary to be a higher level of quality, right? Okay, education. People think tap water's sterile. It's not. We have to be careful how we use it. Don't use tap water as a final rinse for equipment used on patients. Just don't do it, because Legionella and these other organisms are going to be there. High-risk patients need that higher quality. They might need a point-of-use filter on that fixture in the NICU or the bone marrow transplant unit all the time. In the category of education, and where's Doug? I was so proud that he listed his ASSE professional qualification standard for Legionella water safety and management. So in 2020 was the first standard produced by ASSE, the American Society of Sanitary Engineers, and IAPMO, the International Association of Plumbing and Mechanical Officials, for Legionella water safety. What I really love about it is not only does it include education on Legionella, but also other waterborne pathogens and construction and renovation. A very important point when addressing risk of Legionella in new construction. So, well, hit the button again. Whoop, there we go. 24 hours of training. You have to get an 80% on 100 questions, and you're certified. And I would recommend that every one of the institutions represented here have at least one certified individual. I was the first instructor qualified to give the training. Our training, you can see specialpathogenslab.com. Next one is May 1st through 3rd, and then again in July. And then I think there's another one in October. So you register through IAPMO. They manage the education. So have I raised your anxiety level about waterborne pathogens? Have no fear. We have Dr. Stout's Legionella chill pills. Okay, Legionella chill pills. And initially it's just for Legionella, but I've expanded it to include any anxiety you may have at this point about other waterborne pathogens. If you haven't gotten the message yet, the proactive message on validation of water management or just protecting your high-risk individuals, you have to test to protect and test by methods designed to pick up those organisms. You are now officially Legionella and waterborne pathogens party crashers, right? Nobody wants to be a party pooper, but you can be a party crasher. And now you're also part of the mission to end Legionnaire's disease and infections due to waterborne pathogens. So you get the first chill pills. You look like you're really worried now. And with that, I'll take, we're going to do the questions. And I'll just tell you, the first question that I gave, I don't think anybody's going to know the answer, so I might have to tell you the answer. Right, Steve?
Does anyone have any questions for Dr. Stout while I look these up?
And
One quick
yes.
Doctor. So has there been any work done in the study of the core water conservation and the bacteria?
So this is an example of
Real quick,
a good
Janet.
idea.
Janet, could you repeat that
Oh,
question
sure.
for the
So-
virtual folks?
So, we're conserving energy, we're conserving water, right? So there's lots of codes and things like that are out there to reduce water flow through our fixtures. So the question is, has anything sort of shown that has a negative consequence with regard to Legionella and some of these other pathogens? And the answer is yes. And so now you'll find in the literature publications talking about the fact that low-flow devices create the environment that I've just described for optimal microbial growth, including Legionella. So you know, in a place like California, although not recently, where there's been drought, or maybe Arizona, you know, that need to preserve water in the hierarchy of needs may come before Legionella, but you have to be careful about what you're doing. Again, with construction and renovation, how you select fixtures and the design so that you don't create a problem with a solution like that. So great question. I think there was another.
He's got a mic for you.
For healthcare settings and other facilities, I'm thinking large corporate buildings, they're always under financial burdens, constraints. What would you recommend to them, or do you have a recommendation, if they could only test for certain bacteria? I mean, the ones that you showed there, I think there was at least 8, if not 9. But they can't test for everything. So is there a particular indicator bacteria that they would be better off testing for?
So there's a bunch of stuff in there. And I fought during the last public comment period for this proposed standard 514, because this concept of using other organisms as indicator organisms for the presence of Legionella, for example, there are none. Not heterotrophic plate count, not Pseudomonas. There's no correlation of presence or absence with these other organisms. So you can't use an indicator organism to evaluate the risk due to Legionella and these other pathogens. But the other question, and it's a very good one, when there's limited resources, does it make sense to sample for all of these? And the answer is no. And what we say in the plans that we write is that in a healthcare facility, there should be consultation with infection prevention. So infection prevention generally understands what's the baseline level of some of these infections, and when it goes above that baseline. That's a trigger for an environmental investigation. Now, so that is really what should be driven, and why, one of the reasons why having infection prevention on the team is important. The other is that in high-risk areas where we know that infections occur due to some of these organisms like Pseudomonas in NICU, you might want to ask the question, do I have Pseudomonas in the NICU? Because we know that that's tremendously bad outcomes. No, there's nothing more tragic than a baby dying, nothing. And so if you can do some baseline surveillance in a NICU or a bone marrow transplant, how about this? They filter the air with HEPA filters to protect you from breathing in anything in the HVAC system, but then they give you a glass of water from the tap. Makes sense to you? Absolutely not after this lecture, right? So you may want to do something there in that high-risk unit, either do baseline or just go, you know what, we're just going to put point-of-use filters in a bone marrow transplant unit. That would make sense to me. So great two-part question. So thank you for that. And I know Steve's like, gotta go.
That's all right. Thank you guys so much for the questions. I'm going to do the trivia questions, but
Yep.
I do want to say thank you so much, Dr. Stout. Let's give her a round of applause. So question number 1. Why did Legionella cross the road?
This is the one that I said, I don't think they're gonna know the answer to that. Should I tell them?
You tell them.
To get away from Dr. Stout.
Question number 2.
Okay, we're gonna get a
Is
little bit.
Legionella everywhere, otherwise ubiquitous?
False.
Dave Christofferson is correct.
He told me he would share
That is
the.
not true. And so the answer is about half of all buildings are colonized with Legionella, so it is not everywhere.
Yeah, and Doug touched upon that. A certain percentage are positive, so rule of thumb about half.
Last question is, are there at least 1 million or 1 trillion bacteria in your colon gut? Trillion, she got it in the back with the
Yes,
scarf.
isn't that disgusting? But right answer. And I want to tell you, visit our booth in the back. There's more chill pills there for you in case your anxiety gets higher as the day goes on.
So again, thank you. We're getting ready to break for lunch. One thing, so just so you all know, I am not a career MC. This is not my day job. So I have been a bad MC because I forgot to give a special thanks to our co-sponsors, the local APIC chapter and the local ASSE chapter, 𝐒𝐿 Tri-State Healthcare Engineers. They were so kind to allow us to provide CEUs. 𝐒𝐿, I forget the titles that associate with that, 5.5 CEUs. APIC is providing 5.5 CEUs, and public health folks are also qualified for 5.5 CEUs today as well. So I wanted to make mention of that. Lastly, Amy is on my team right here. She mentioned to me that Solid Blend is actually not on your passport card. Our booth is right over here. I want to make sure you guys get a chance to go visit whoever happens to be working the booth at that time. Buffet line starts, I don't know the answer to that, over this way. Somebody give me direction. Back where the breakfast was? Okay, perfect. So buffet, we've got about 30 minutes for lunch. I'll kind of start bringing you back. I know we got a lot of folks to get through the buffet, and again, we've got a little bit of wiggle room with time. So thanks for your attention. Enjoy the lunch, and we'll check back in with you in about 30 minutes. All righty. I know you are having a blast out there meeting people and talking water, among other things. But I'd like for us to make our way back to our tables, start to quiet the room down, please. I'd like to get Dave introduced so we can kind of stay on track. Dave, we cut into a little bit of your time, so don't worry about ending right on time. I think if we go into the panel time a little bit, that'll be fine, just so you know. Dave is scheduled to speak until 1:30. Dave, I'm going to give you to about 1:40. We'll start the panel probably around 1:45. That gives us a few minutes to set up the panelists. So Dave Christofferson is up next. Dave Christofferson is with Dave Christofferson Consulting. So Dave is an extremely knowledgeable person in regards to wastewater treatment, boiler water treatment, pre-treatment, cooling towers. So a lot of the stuff that we haven't dug really deep into in the facility side of a hospital, for example, with your steam boilers, your cooling towers, those types of things. So Dave has 45 years of experience in the water treatment industry, so managing water treatment programs for industrial sites, cooling systems, wastewater systems, membrane-type pretreatment systems. He's done a lot of field pilots for various chemical and equipment applications. He's conducted a lot of trainings on many topics of the water treatment industry, water treatment chemistry, boiler and cooling systems and treatment, wastewater, as I mentioned. So Dave spent his career at several different water treatment firms. Locally here, he spent a lot of time with Crown Solutions out of Vandalia, Ohio. They strategically sold that business to Veolia, which is a global water treatment provider. And he was the technical director, if I'm getting that right, for them. So just a wealth of knowledge coming up. And if I could, help me in welcoming Dave Christofferson.
I don't know. I have no idea. Somebody else picked that for me. Yeah, sure. So I was told I could walk up with an attitude. Janet had a little bit of an attitude when she walked up, but I don't even know how to have an attitude. But how's this for an attitude? They put me on after lunch for an hour and 15 minutes when everybody else wants to be sleeping, right? Thanks a lot. That's my attitude. Well, here's another attitude. They put me on after 3 great speakers who's totally covered all the subject matter, and I'm supposed to talk for an hour and 15 minutes. So how's that for an attitude? Actually, I kind of was out at my car and rewrote everything, because everything I had to say was gone. So I'm just going to talk about stuff that's interesting to me, really. that's fun, really has nothing to do with why you're here. We'll just see where it goes, okay? So, actually, that's not even interesting to me. When I was in college, undergraduate, my inorganic prof made us memorize the periodic table. Of course, who said that? Okay, of course, yeah, not a course. I was like, seriously? Dr. Condor, what chemistry lab doesn't have a periodic table hanging up, you know? But we had to know everything. We had to know the groups, the atomic weight, numbers, the electron orbitals. And it wasn't just because we had to regurgitate that. No, when they gave you a test, you needed that information to solve problems on the test. So if you didn't have that memorized, you're totally out of it. So actually, I said, so what's the purpose? And he said, Dave, there's just some things you need to know. So that actually resonates with me more now than it did. I was like, are you kidding? I have a party to go to tonight. I don't have time for that. So, but it's kind of what I'm going to talk about. And so what I did just say is, it's a little bit true. I'm going to talk about some other things, but stick with me because it's all going to come together, all right? Because it's kind of a pet peeve of mine. I do a lot of training, so I know how people behave. I know I've had to study this because I've had to teach it. So, you know, if you want to learn something, teach it, because now you got to really learn it to be able to teach it, right? So knowledge is the starting point. I'm going to be talking about big picture stuff. So I'll just tell you here, the big picture, what I hope to accomplish, not just Legionella, but the whole risk assessment process for water systems. So I'm involved in a lot of different types of waters, and I created an index, and I'll explain that to you. Because if I'm going to a plant trying to solve a problem, the first thing I want to do is, as quickly as I can, identify what I'm walking into. You know, sometimes it's an emergency, so you want to figure that out pretty quick. Other times you have more time, but immediately I want to know, am I in a bad situation? Is this a low risk situation, medium risk, or high risk? When I first developed my index, I did it on a scale of 1 to 10. And the reason I created this thing was because I wanted to force the right questions to be asked, the right investigations to go on, and it was too onus. I simplified it to a 1, 2, and 3, so I'll talk about that. So low, medium, and high risk, that's the big thing. So we can talk about lower high risk Legionella situations. We've already done that a lot already with the 3 speakers that stole half of my material. So I'm not going to do that a whole lot, but I am going to talk about knowledge and how to learn. I'm going to talk about 3 books I've read recently that I think you'd be really interested in reading, and I'll explain some of the stuff I learned from that. And then I'm going to tie that to the whole process of risk assessment and how to use that information. That's my goal. Another big picture item that I want to bring up now in case I forget during the talk is one thing that I've learned in water treatment that I didn't know when I first started after I had memorized the periodic table and got into actual industrial water treatment, is that water treatment isn't about the normal, typical. We design for the normal, typical. So we've got that licked for the most part. We know the systems, the types of water, building water, cooling towers, everything else, the scaling potential, the corrosion potential. We have that understood. And we do a pretty good job of setting up programs to maintain that. But most water treatment programs are a consequence of setting up a bad program. Most water treatment problems are the other 5% or the other 1%, the things that happened, you know, that you didn't plan for, that you didn't even know to ask questions around. So when you're doing risk assessment, the easy part is asking the normal questions. The hard part, and maybe the most valuable part, is anticipating those other things, those abnormal times. So if I forget that sometime in my presentation, that's one of the takeaways here. So I'm going to talk about knowledge and understanding, listening, learning, and I'm going to steal some stuff, and I believe this is from Albert Einstein. So first of all, you know, you've all heard we don't know what we don't know, and that's a problem. It's a problem if you know that and don't do anything about it, and it's a problem if you don't know that. So I saw this really cool thing that as we learn, we become more aware, right? And we get more base knowledge. So human knowledge, I don't know how they measure this, but in 1900, our human knowledge growth curve was we were doubling information every 100 years, right? In 1945, because of all our stuff, all of our mechanisms and improvements in technology, civilization, in 1945, it was 25 years. In 1982, guess how fast we're doubling information? 1982. Huh?
10 years?
Almost 12 to 13 months, so 1 year. So in 1982, we were doubling human knowledge every year. Guess what it is almost now? I should give away everything that's here if you get this right. And beer for a year at Grayman's. Pretty darn close. 24 hours, he said, it's 12 to 13 hours. We're approaching doubling. That's a lot of information. So I was thinking about that. How much of that is useful information? You know, I'll bet you we're doubling information, but I'm not sure our real useful information is going up that fast. Do you? No. So how do we assess useful information? So I requalified this to useful information. And this is the Einstein hypothesis. If you draw a circle, and it doesn't really matter how big you make this circle when you see a little further, but this first circle, and you put everything you know in there, what you know. Okay, not what is known, but what you know. What's outside that circle? Okay, so that's infinity. That's everything we don't know. Of course, that's increasing all the time. So again, this should be another prize. What does the line represent? Say it again.
What we're learning.
It's kind of very close. That would be like half an apple, maybe, or whatever. Let's call it, oops. It's what we know that we don't know. So it's pretty close to what you said. But that line is an awareness of things that we don't know. So what happens when that circle grows? Well, first of all, we get better. We have more capability. We have more capability to understand all the words that I could never say that those two were saying, right? We have more capability, so we're becoming better. We're going to become better. Our knowledge base is better, so we can do things better. We can anticipate things better. We can ask the right questions better. But to me, the most important, whoops, I went too far. That's why there's a back button. The outside stays the same. I mean, it's still infinite. So relative to what's out there, it's almost didn't change, but it did change because that's stuff we need to know. So our concentrated area, if we're in water treatment, I gotta know a bunch of stuff. And I wanna continuously know more stuff to help do a better job. And it also gives me a capability that line represents. And that's stuff, that's awareness that I know what I don't know. Right? And that improves you evaluate how to evaluate risks. So having knowledge helps you evaluate risk, but that awareness that there's so many things that you don't know helps you evaluate risk also. So I'm trying to think of how to do this. I have a training coming up in Saudi Arabia with a whole bunch of people, and I want to explain to them that I don't want to do training and click a box and then fly home. I want them to understand it all, to take it with them. So I was trying to think of how am I going to make that impression. And it doesn't matter what the right side of that is. It's some water system. It could be a building water supply for Legionella. It could be a cooling tower. It could be a boiler. It could be a reverse osmosis machine, a wastewater treatment plant. But there's something there, right? And if you're knowledgeable about that, how it should run, what it should look like, what it should smell like, all those kinds of things, that's helpful. When you walk by that, if you're a water treater, if there's a light that also comes with that piece of equipment and it's flashing, That's a pretty good thing. That says, hey, I'm flashing. And so you're saying, well, I wonder why that thing is flashing. And you go, there might be something wrong. And you go home and you think, I wonder what that was wrong. Maybe I'll call the plant manager tomorrow. And I said, hey, your light was flashing, by the way. And he says, you're kidding me. And you didn't do anything? What if light flashing means I'm going to have a nuclear meltdown, and do something now, right now? So if you don't have knowledge to know what's it's supposed to look like, most of the time that light's not there. It's not. So what is there are a whole bunch of clues. And that's what a water treater's job is to look at all the clues and take advantage of what you know and what you know you don't know and assess it. So we'll talk a little bit more about that. But knowledge is the starting point for that. So I think it's true. For sure, I know it's true in the water treatment profession, but I think it's true in most all professions, frankly, is when we start, we have a pretty limited base knowledge, right? And then we need to become comfortable with what we're been assigned to do. So we make a pretty strong effort to get more knowledgeable. We grow, and we do the effort. Most people do that effort until they can do their job satisfactorily. Their boss isn't mad at them anymore, but they have other things to do. So very commonly we plateau. What's very unusual is for somebody to keep going, over the course of their career. Doctors have to almost, because medicine changes so quickly and they're obligated to. But if we're doubling our knowledge base every 12 hours, I think maybe we need to reassess a little bit of our knowledge base and think about it. So the yellow light isn't always there, but that's how I think we could think about things. So if you're not comfortable assessing anything you're responsible for because you don't know all the right questions to ask and how it should taste, smell, look, operate, anything, then that means I got to move up. I got to move up. So learning, listening, understanding. Right now I'm scheduled to talk for an hour and 15 minutes. And you know what the military does? You know what a debriefing time is for a military? How many people's been in the military? Nobody, a couple people. 20 minutes, right? Okay, 20 minutes. You better tell me everything that's important in 20 minutes. You know why? Because after 20 minutes, my brain shuts down, which I'm anticipating here. And I feel perfectly fine, walking around and nudging you and trying to pick you back up. But you got to start with what's really human nature. And human nature is we suck at listening. Not just a few of us, almost everybody. If you find a good listener, they've been trained on how to be a good listener because it doesn't come naturally. You're just bad at it. So right now, I could embarrass a whole lot of people here if I just went around the room and said, what did I just say? I'm not going to do that. Well, maybe if there's somebody I see here I don't like that much. But that's true. So you start with that. You start with, I'm not a good listener. Why is it important? Because if you don't listen well, you're not going to remember something. There's a few books, and I'll give you the references to them. If you forget where you parked your car, chances are it's because you paid no attention where you parked your car. So how are you going to remember where you parked your car if you didn't make an intentional effort to remember where you parked your car? So when I go out with my wife, she never turns the right direction. We walk out of the restaurant, she goes that way, I go this way. And she goes, well, why didn't you tell me? And I go, why didn't you pay attention? You can't learn things if you don't pay attention. So listening is part of that. So there's all sorts of different levels of listening. One is to be an active listener, which means you're bad at it, so you got to keep doing that. You have to stay focused. You have to clear out of that email that I have to answer in a few minutes, or what I just heard from, or whatever those things are. If it's not important, then forget it. You know why? Because our brains are wired to forget. They're not wired to remember. Our brain definitely wants to forget just about everything I'm telling you right now. That's not me. That's some of the newest information that's out there. There's a lady named Lisa Genova who wrote a book, Remembering, and it's how to learn all this stuff. And the first thing she tells you is, unless you try, forget it, because if I have a long sentence, you can't even remember what the beginning of the sentence was. You have 15 to 30 seconds. That's how long your momentary memory takes it before it throws it out. The only reason it staves it is you go, hey, I got to remember that, or I'm going to write it down, or I'm going to do something intentional because my brain wants to forget stuff. Because if I try to remember everything that I see around me, my brain's just going to blow up. So it's wired to forget, not to learn, not to remember. So that's a good thing to know too, because the next step is it goes to your hippocampus, and you sleep on it overnight, and during the night, your hippocampus subconsciously decides whether that was valuable or not. So you may want to think this is valuable right now, and you're going to try to remember it, but unless you really make a more conscious effort, there's a pretty good chance your hippocampus says, nah, and he throws it out overnight, or she throws it out overnight. So there's a process that you have to go through. After that, if you've made some really strong efforts, then it starts storing it in different parts of your brain. And there's not just like this memory part of your brain. Your whole brain remembers things. And so that's why it's good if you have a nice social event and you had a really good beer, and you taste that beer and you're with somebody that you really like, or is very handsome or very pretty, or there was some song playing that you really liked. That goes into different places in your brain. And why that is so helpful is then you have different avenues to draw from to remember it, because one went in and you're associated with the good taste of the beer. The other one, it was the person you were with, the music that you were hearing. And so as you get older, when some of those synapses get plugged up with all this crap, and it doesn't come through that way anymore, luckily it comes over this way, you know? So it's an interesting thing to learn how you learn and how you have to understand things, because I don't know how you do it, but unless I've practiced it, unless I wrote it down, unless I come back tomorrow and look at it, and a few days later, and a week later, chances are my hippocampus is going to throw it out. You know, so if something's important to you, that's going to be not, you know, a knowledge base that you want to keep long term, you better make an effort to do that, because otherwise, your brain goes, no, nope, not doing it. So I'll show you that book. Another book is, it's called 7.5 Lessons About the Brain, and it's a new book too. Both of these authors are PhD neurologists from Boston. I don't even know if they knew each other. Books came out a little bit around the same time, I think. But the 7.5, what, did she get too tired to finish the other half? Actually, that was the first chapter, and she says it's just too much material, so I'm only going to touch on it. So that was the half. The half lesson is basically the evolution of the brain, how it's developed. And what do you think the brain was, how it progressed? What was the progression centered around? What do you think the purpose of the brain was? Our brain. I'm talking about the human brain. Huh? Survival? That's another chapter. I'll tell you about that chapter too. It's not about thinking. That's what most people think. It's not about thinking. The brain was not about thinking. It's about bodily functions, to conserve energy, to be efficient at my body. So maybe protection is one of those things, but all of those things, it doesn't evolve with a purpose. It evolves all about, you know, efficiency around body. So the other more recent information, and somebody mentioned this, survival, that's the reptile brain. You know, so we have emotional brain, we have conscious effort, thinking brain, we have this lizard, reptile, fight or flight kind of brain. So everybody always thought, until recently, and you can still read about it, you know, if you Google it, that there's 3 sections of the brain. No, the new thinking says that's wrong. It's all one. It's one brain. There's no to these 3 different divisions. How do we know that? Because you can look at cellular structure, you can look at the way the brain fires now and everything. It's just one brain. Different functions of the brain have different certain responsibilities and stuff, but we don't have 3 separate brains. We have one brain. So that's good to know, because I always thought, you know, I was cheated on some parts of the brain, but it's all one part of the brain now. So really interesting things that you can learn that's new knowledge. It's not stuff that if you I graduated from college in 1978. How much of that information is still valid? Well, the periodic table is, but so much has changed. And so much has changed in Legionella management and what we've learned and so forth. So the first thing is challenge yourself on what you think you know, because the other book that I think is really applicable out of these 3 books is a book by Adam Grant called Think Again, The Power of Knowing What You Don't Know. So think about that. Think again, the power of knowing what you don't know. So here's the problem. Most people don't even recognize that their information may be wrong. What if you had a presentation that you were at, whether it was this one or something, and Janet told you something that was totally wrong? What if Legionella didn't really have a party in their pipes? And what if the Legionella really wasn't the cool one with the glasses on? You don't know that. You believed her, So you wrote that down, you go home. But what if that was wrong? You just stored information through your short-term memory, through your hippocampus, into different parts of your brain, and it's wrong. Yesterday, 2 days ago, I got a phone call from one of my clients, and they go, what happens when you have silica break in a high demineralizer for a high-pressure boiler? Does connectivity go up? And I go, no, connectivity goes down because silica breaks, silica goes up, but connectivity goes down. And he goes, how can I have been in water treatment for 25 years and not know that? And I go, well, you're just not as good as me, that's why. Then I went home and I looked it up. I need to call him back. Because it doesn't necessarily go down, it doesn't go up, stays the same, but there are conditions where it can go down. My memory said, always, when silica breaks, connectivity goes down. My information was wrong, okay? So either I remembered it wrong or it was wrong. So, interesting. So, this other lady on memory, this is really gonna concern you. Every time we draw our memory from whatever memory bank we can, it doesn't restore it the way it was before. So every time you use your memory, the next time you use your memory, that memory is different. So she puts it this way. Let's say that you and your wife or you and your husband have a fight over something, and you say it was this way, and she says it was that way. And you know that commercial where they drop the red flags, and then they play it back? Yeah? She said, well, chances are you're both wrong, because neither one of you remember it correctly. So one may be right or more right than the other, but you may both be wrong. So why am I telling you all this? I told you because I had everything else taken away, and I'm just going to talk about stuff that's fun to me. So this is fun to me, but actually I think it's very useful. It's very useful when you begin becoming responsible for certain processes, for certain operations. When people ask you to be part of their water safety committee, and you're the one trying to help evaluate, let's say, the critical control paths. If you don't have a knowledge base for doing that, if you don't have the experience, are you really doing a good job? And if you don't understand that you're not always right, and what you think is right, unless you're willing to say, wait a minute, I really need to go back and look at my notes. I can't tell you, after I read this book, I started going back and looking at stuff that I thought I knew. My own notes told me I was wrong. I had numbers in my head that were wrong. I had, processes that weren't right. I must have called them back too many times and I totally changed them, or I just learned it wrong. So be willing to do that, I guess, is my message here. How much time did I take to install just before? Okay. So this is a water treater. I'm trying to think of ways to put this. If you understand what the sunny days look like, and you can predict the storms and how to design and plan your nice family picnic and fun time for the nice day, you better anticipate that sooner or later that hurricane's going to come. It may not happen. It's that less than 1% of the time or less than 5% of the time. Hurricanes way less than that. But if you don't have hurricane construction, everything's destroyed. Water treatment's like that too. Because if you get infested and you have Legionella, that's a lot harder to control now and manage than when you first started and you didn't have anything in there. If you allow a cooling system to corrode, how are you going to fix that corrosion? You're not. It's already corroded. If you let it scale, your chemicals, for the most part in water treatment, are to prevent scale, not to clean scale. So once it happens, people go, well, we'll just increase the dosage of the chemical. No, it doesn't work like that. As a matter of fact, it might make it worse. So if you didn't head off those problems, that's a major failure, really, I think, from doing what your job is, and that is to anticipate for the stormy days and then have the right plan in place. So that's the best I could do. I like the flower base and vase and the flowers in there, but this was my effort. So how is it supposed to be? How is it now? And then how to predict and prevent the disasters. So that's part of risk management. The big picture on risk management is I have a little bit of water safety plan stuff in here, but you've really gotten into some of the details, how you do a water safety plan around Legionella. So I'm going to talk, I still use this on a Legionella safety plan or a basis for that before I do the specific part. You have to do a specific water plan. But overall, I still want to do the big picture stuff. So if you're a water treater, and there's not that many water treaters in here, so I think this is a worthwhile slide, because when I talk to clients or building property owners, industrial plant managers, stuff like that, water is water to them, right? But to a water treater, water is not water. And we don't even really look at water. We look at what's in the water, the constituents of the water. What's our components of that? And that's one of the risk factors, really, starting with the water quality. So in my risk factor index, we have 3 main columns, and I'll talk about that. But the first one is the water itself. So Janet mentioned, I think, that if it's a surface water, you got a lot greater concern, probably, for those little dickens with the sunglasses on to get through the water system. So water quality is important, and sometimes we miss a lot of the analytical part of it. We just look at calcium, iron, magnesium, some of that stuff. But there's a lot of components to water that will affect, and in Legionella, it's nutrient loading, besides all these other environmental conditions. And I'll talk, if you remind me, a little bit about biofilm, because a couple people brought it up, and I think it's a really interesting conversation, because I think in Legionella sampling and in Legionella control, you've got treated and untreated systems. Normally a building water is untreated. You can treat it like Sanipures out here, have secondary disinfection, but a cooling tower is a treated system. So from a biofilm standpoint, and why am I talking about biofilm? Because Legionella is in biofilm. So you don't talk about Legionella generally without talking about biofilm and biofilm control. So it's all about biofilm for me in industrial cooling towers and operations. And what does that mean to me? It means, what steady state am I in from my biofilm? Am I in a steady state? What's the likelihood I'm in a steady state in a cooling tower system? Not very likely. You're not in a steady state because there's so many variables. There's process changes, there's flow changes, there's water hammer. What's their feed cycle of chemicals? What chemicals are they using? You're disrupting biofilm all the time. So the biofilm is either in a growth or a shrinking method as flow changes. So you're releasing things. So when do I sample? Based on when biofilm formed. I'll get more into biofilm. I got a little distracted. So what's in the water? That's one of the things. I wish I could see better what I have up here. Okay. Maybe this one's better. There we go. The other thing that's really important on this is not just the water itself, but the variability in the water. So if I have a consistent water quality and I have processes, equipment, chemistries and stuff that can manage that, then I'm fine, as long as I assess that. But now you put variability in there, and now my ranges of different things change considerably, unpredictably maybe even. That makes it a whole lot harder. So it's not just the water. I could have a pretty good water quality, but a lot of variability, and to me that might be a higher risk than a poor water quality, but at least it's consistent. So some municipalities have multiple sources of water, and they change. You don't know. You might get water out of a river, water out of a well, water out of a reservoir, and all three of them have differences. That's goofy, because how do you design for that if you're a water treater? When I first moved to Dayton, I hadn't treated Dayton city water. I moved from Indianapolis, and I was running LSIs and trying to determine what was a safe cycle. And sometimes a safe cycle's concentration was 5, sometimes it was 4. If you don't know what cycles means, it's how many times, it's the ratio of how much water you make up to how much you get rid of or blow down, which consequentially increases the total dissolved solids. So if you're 5 times, you've concentrated the TDS 5 times. I couldn't understand why it changed so much, because Dayton water is a cold lime softened water from wells. It should be pretty consistent. So I pursued it. You know what caused the water change? Take a guess. Obviously, treatment. But why? They rotated operators every 2 months. And one operator liked to operate on the high end of the scale. The other operator found it better to operate on the low end of the scale. They were both very consistent, but both very different. The total difference were 2 guys, basically, the lead operator, and then when they changed. So your water quality changed based on 2 guys in Dayton for a long period of time. I don't know if that's true today, but it's like, I didn't know that. If I didn't know that, how do I compensate for that? Because if I design for 4 cycles and the operator changed, or I designed for 5 cycles, and the operator changed, I may be in problems. So water quality and variability is one. The water itself, if you don't know this, is called the universal solvent. So it's dissolving stuff. It wants to dissolve the pipes. It wants to dissolve things, all sorts of things, inorganic and organic things. So we have to look at that. We have to look at potential deposits, whether that's in a building water system, in the hot water systems, in cooling towers and boilers. So a water treater has to understand all of the different variables that could cause scale and different types of scales. Microbiological is what we've been talking about here. But in cooling systems, we monitor and try to minimize Legionella. But if you sterilize a system and you do a sterilization and it doesn't like 122 and it dies at 148, I want 180 or 200. I want to kill everything, because I know that bacteria like to hide under biofilm. I want to get rid of biofilm, not just those Legionella. And I want to kill sulfate-reducing bacteria, so I want to get the pipe hot too and everything else. So it's not just about Legionella, it's about biofilm also. And so I can eradicate maybe or reduce the Legionella, but at the same time it makes sense, since Legionella is dependent on biofilm, to do something about the biofilm also. So I'm going to use this as an example as I lead into my risk assessment strategy and my index. So this was a gold mine in Ghana, Africa. So if you haven't been to Ghana, it's kind of a third world country. They don't have a whole lot of analytical labs, maybe 1 or 2 in Accra. Most of them don't even know where Accra is from these villages and how to send a lab there. So you go there and you ask for a water analysis, and there isn't any. You don't have some, but we'll work on that. We'll figure out how to send it to Germany or wherever. This was a brand new operating contract for the company I used to work for. It used to be operated by an Israeli company. They put in the equipment. They put in all wrong equipment. Totally wrong equipment. They should have had a clarifier. See how dirty that water is on the left? That's their gold mine water. Their treated water that they have to treat pure enough that they can discharge it into a river, according to Ghana EPA standards. So they needed mine standards, global mine standards, are very, very high purity requirements. You have to get rid of very, very low levels of metals. So this is my first day there. And I'm like trying to assess what their needs are, because the plant manager and the assistant plant manager are not water treaters, and they don't have water treatment experience. The operators used to operate for the Israeli company. The Israeli company didn't want them to be too smart, because they didn't want, I don't know what the reason was for that. So I'm trying to assess on my first day there if this is high risk or low risk. Anybody know what reverse osmosis is? Yeah? Okay. So a reverse osmosis machine requires high purity water or good quality water going to it to take out total dissolved solids. It's not designed to take out stuff that other things should take out. And this water was operating in a super concentrated solution. So super saturated in calcium carbonate, in aluminum, a lot of stuff that's bad news and dependent on chemicals to prevent it from scaling. And in scales, you have what's called an induction time. So chemicals can delay the precipitation, but they're just saying, I'll delay it and it'll happen later. Okay, so that's how they work. So I'm sitting there talking to the plant manager, getting all this operations going in his trailer, and all of a sudden the lights go out and it's dark. And he just keeps talking like he doesn't even know that I know the lights just went out. And I was like, what, Fred, what's going on here? That happens all the time. And I go, what do you mean all the time? He goes, yeah, I mean, regular, it's unpredictable, but I mean, it could come back on in 5 minutes or maybe a couple hours. It may not be till tonight. And I said, well, what are you doing with your RO? And he goes, what do you mean, what am I doing? I go, oh, jeez, take some notes. Because if you shut down an RO, it's in a supersaturated situation, you have minutes to get that flushed out when you shut down. So a normal design has a post-flush on it because you've delayed scale on a lot of waters that go to it, but it's not gonna stay prevented very long. As soon as you shut down, you got a post-flush. So they were going through membranes, and understandably so. They had to meet EPA discharge. So I was like, high risk, you know. They had the wrong equipment. That picture on the right is me training all the staff. They didn't have anybody there that knew how to operate the plant. I mean, I went around and we made a list of like 68 things that needed to get done and then prioritized them. So what would you make from this if you were me? Besides going, I'm gonna be here for a while. From a water standpoint, it was a high-risk water. This is a highly variable water with some really bad stuff in it. So it's a high-risk water and it had high variability. The operations and control, they did pH adjust before a multimedia filter, feeding acid out of a 1-inch line on and off with no pH controller, trying to target a pH of 6.8. No, that's not gonna work. They had equipment that was the wrong equipment. They didn't have a clarifier, they had a settler. They didn't have, I mean, so it's a high-risk operation, it's a high-risk water, it's a high-risk equipment. Everything about it says you got a lot of things you need to do, okay? So I have, I did my fit quick on that, and that was easy. I have a lot of things to address. Everything's risky here. What is risk in a water system? So that's one of the first steps, is identifying what's a successful outcome, right? So if my successful outcome is the property manager here that runs the gold mine, that I have to be up and running, processing gold, and meet my discharge limits, that's what his assessment is for success, right? I'm making gold, I'm making money, and I don't have the EPA on my back. I'm discharging water according to this. So if I did this risk assessment, I said, Fred, you need to go to the plant manager and tell, first of all, his costs are gonna be high here because you're gonna be damaging all sorts of stuff unless you give me a generator or a flush tank, something. You're gonna be in violation, so that if the EPA catches you, you're gonna be shut down, you know? So you're gonna hurt all these things. So his definition of success are probably those two. Somebody else's might be on the operator standpoint, but my job is to just keep the RO running, so that might be his level of success. So you have to assess risk around each one of those units of operation, and also based on what your responsibility is. So the plant manager, the operator, the facility manager, they all have different successful outcomes, and you have to do a risk assessment and criteria around each one of those. But here, I tried to simplify it and broke it down into 3 major columns. So water and variability is one, operations and equipment, or operations and control is the second, and then equipment and design. Okay, so for example, if you have an RO machine and you need to have 100% of the time up and running, and you only have one RO and you know you have to clean it once a month, is that a good design? No, it's high risk because that says I can't shut down. So you would have to have an N+1 design, which means I should have 2 ROs, one running and the other one available, so that when I have to clean this one, I can go to the other one. So those are the decision-making processes. Because this is high risk, what do I do with that information? I use that information and said, these are changes that we have to make if you want to meet your success criteria. So those are the 3 columns. water operational. And so here's a few examples of how you use the information. Chemical dosage versus risk and results. Let's go back to a cooling tower. Let's say to prevent scale and corrosion in a cooling tower, I need some product at 25 ppm. Okay, so this on the left side is just some sort of arbitrary number. So let's make it more accurate. Let's say I need 8 ppm. So instead of putting, I put this in layman's terms. Okay, so on the bottom, if I am below 2 ppm or 1 ppm, I know based on experience the water quality at those cycles of concentrations, and I'm only at 1 ppm, I'm going to have problems. And I can tell you, you're going to have problems. This is not going to be good. If it's maybe up to 3, I haven't accounted for a lot of variability. I haven't accounted for those upstate conditions now. That's just the bare minimum. I say, it could work if everything else goes right, okay? Or I could say, you're probably okay. But really, where we want on this example is be somewhere where I can say, yeah, I can pretty much guarantee it, or you're close enough that I can pretty much say this is good. And then you say, well, we'll just feed a bunch extra because I don't care about costs and everything else. And I go, no, that's not good either, because some of those chemicals work in the opposite direction if you get overdosed, okay? So there's an optimum point to be on chemical treatment. There's an optimum place to be if you're doing sterilization, if you're trying to control bacteria, biofilm, and so forth. Under and over isn't necessarily good. Another example is product itself. Some people will look at a product, they'll look at some of the active components of that product, and they'll compare it to a competitive product, and they go, those are the two same products. Probably not. You don't know the details behind it. Oftentimes, the detail are in the last two components on this example, the polymer selected and the concentration of those polymers. That's probably half or more of the cost. One's designed for a low stress situation, one's designed for a high stress situation. If you don't know that, if you don't have the base knowledge, the base experience, you might say, I'll go with that lower cost product, the one on the right, instead of the robust product, right? So how did you do this? Well, you did this with knowledge and with your risk assessment. Service level, okay, so I would not, to that gold mine that I went to in Ghana, I would not send somebody that's been in water treatment for 2 years. He wouldn't even know, or she wouldn't even know where to begin, okay? Because you have to have been there, done that on a lot of these different things. So that's part of the risk assessment too. How difficult is this job? If it's a low risk water, low risk operation, maybe this is a good job for this person. If it's a high risk, problematic customer who knows that he has a difficult situation, knows he wants to talk to somebody that's been there, done that, that's a different situation, right? So again, that's part of the risk assessment. If I'm going to try to minimize whatever potential problems there are for this place, then I better make sure I have the right quality of person for the right amount of time. So I don't really need to go quite to that yet. Let's talk about the service numbers then in this risk factor index. So for me, it's a thing that I always did anyways. I always assessed as soon as I got there, is this a, what kind of situation am I in? But then I formalized it. And why did I formalize it? Because it provides an opportunity to do something. It requires you to create a bunch of questions to be able to say, did I adequately assess that? Is that a low risk? Is that really a low risk? And what questions did you ask? And what knowledge do you have? Did I accurately assess that? A lot of times the answer is, oh, I didn't, especially if I get 2 or 3 people involved and the other person knows stuff that you didn't know, and he goes, well, wait a minute, what about this? What about that? What about that? So a formal process helps you really do a good job of doing the risk assessment, okay? So if you assign numbers to it, I created it, I called it the WHOA risk factor. WHOA is not because woe is me, because you remember water, operations, and equipment. So if my risk factor index is 1 to 1, that means I have a low risk water with medium risk operations and low risk equipment. If it's 333, it doesn't matter. Everything's across. Like that gold mine was a 333. So the risk factor index is useful in trying to say, where do I need to target my effort? You know, because all three of those are important. If I had a low risk water on crappy equipment, I'm going to have problems. If I have a low risk water and nobody's looking after the operations, I'm going to have problems. So just because I have a low risk water doesn't mean I'm not going to have problems, right? So you have to look at all three of those and say, well, what's the likelihood that I'm going to have my successful outcome that I want? And that's the value of it. So the value of it then is I go to the plant manager at this gold mine and I said, you are operating in a high-risk situation that's going to compromise your budget. It's going to compromise you staying out of jail. It's going to compromise your money, your value, here. And here's why. We did a risk assessment, and here's all the things that we asked, we looked into, and it's a formal process for now you can use for communicating and saying, this is what needs to get done, and this is why. This is why you need to spend this money. You need to dedicate this. You need to buy a generator or whatever. I'll see what I had left on Legionella, and then I'll get into a couple other kind of case studies. You know, it's kind of this, there's three pillars to this also, just like there was three pillars to water, operations, and equipment, right? If I don't have a host, well, I don't care what level of Legionella is in there, right? But they're not harming me, they're having a party, you know? Have fun, I don't care. But if I don't have a way of transmitting it either, if I'm not aerosoling it, you know, it's in there, but I'm not inhaling it, I'm not getting aerosols, right? So there's really three pillars too. You don't have to necessarily go 1-1-1 on all of those if your ultimate design is prevent Legionnaire's disease, you know? I would want to minimize exposure. I would want to minimize, you know, the chance that Legionella are in there or the level that's in there. I'd want to do everything I could. Former company I had, I was on their water safety plan, and their strategy was, I don't want to ever detect a Legionella. So they were very, very explicit on all the things that they had to do, and they had done extremely detailed field analysis, did this, did all the testing. What's the probability that I got non-detect on Legionella on every sample? Because their theory was, as long as I'm near at non-detect, but that doesn't mean there's not something in there, it's just low, then that minimizes the risk. So that was their approach. Why did they do that? Because the CEO said, that's what I want done, because they had 3 people that died from Legionnaire's disease at one of their operating contracts. So he said, this is that's just not going to happen. So I don't know what you have to do, but make sure that we never test positive. That didn't always happen, but I can tell you that they did all those things, and you would sample it, and 99.some% of the time, it was below 1 CFU per mil. So that's an extreme strategy, but it's, you know, it might be one to do. So from a risk standpoint, again, let's look at all 3 pillars and take care of all 3. If you take care of all 3, then the risk is lower. I don't need to hit this because we know it's everywhere. It's not ubiquitous. I have a hat to prove it. How does it infect? Well, we know all the different entry points, pretty much. We've hit those. We know that this poor hotel should never have been built in the first place, or we wouldn't have all these problems we have today. Water safety plan, I think we've pretty much nailed that to death. So again, this is going pretty quick. For me, again, the water safety plan comes after I do this initial risk assessment. So let me ask you a couple questions. If you have that bottled water sample there, I saw that. I was going to try to grab one, but I didn't know that was yours. So not in counting that we both just touched this and so forth, one thing that I do, and I think when somebody's drinking a glass of water like this, I go, I wonder what the safety is of this water versus that water I'm getting out of the bucket over there. And where did that bucket of water come from? I'm assuming it's municipal water, right? So which is a safer water for, let's just start with drinking. No, I tell you what, let's go back even. What do you think water costs around here? What Cincinnati Public Works charges for water? Any idea? Does anybody know? Did anybody ever look at their water bill except during summer when you're watering your lawn? How much? 8 cents a what? Gallon? CCF. No, that's be good water. I mean, I could go for that. A CCF is 748 gallons. So no, it's close to. They just raised the rate, so it's a little over $4 per 1,000 gallons. Okay, so for you to use 1,000 gallons, you're out part of a nice beer here. But if you bought this, how much would you have paid for a pint of water? $4 for a pint? Oh, you're changing my math, but I can accommodate for that. I tell you what, just make it easy for me. Thank you. Who did that? $1 for that. So what does that make a gallon of water cost? $8 a gallon, right? 8 times a pint. 8 pints. Are there 8 pints in a gallon? Yeah. So you can buy that water, 1,000 gallons for $4, or you can buy 1 gallon for $8. What is the comparison? How much more expensive is this bottled water than that tap water over there? Yeah, 2,000 times. So I would think if this costs 2,000 times that this should be a better water, a better safe water to drink. It's not regulated. Well, it's kind of regulated. So, okay, you bring that up. Yeah, are you at a water treatment plant?
Sort of.
Are you a regulator?
No, VA hospital.
Okay. Okay, I just don't like to get in arguments when regulators. Okay. So, who controls this? Who looks after this? FDA. So the FDA is looking after your bottled water. The EPA is looking after that water. So who does a better job of looking after your water, the FDA or the EPA? You think the EPA does? What do you think? I think that's a good answer. That's a very safe answer. That's a good career builder answer. The thing is, safety and water safety doesn't necessarily follow cost, does it? Because that water, I can tell you for sure that water is not 2,000 times safer than Cincinnati water. So the first thing I would say is, from a risk and a knowledge standpoint, when you see somebody drinking out of a drinking fountain, are you a nerd like me and wonder how safe is that water? And you do the risk assessment on that? First of all, hardly anybody drinks out of the water fountain anymore, do they? They fill up, something else. So they just change their distribution system a little bit. So is that improving it or making it worse? It depends what I'm putting it in, right? So if you look at the city water, the piping drawing that Janet put up there, you've got water quality coming out of Cincinnati. We're using Cincinnati since we're here. Water, it's pretty good water because it's regulated by the EPA. They're monitoring, doing all the tests. It's got a ppm of free chlorine in it. It's below all the different, best guidelines. So it's pretty good water. But what happens after that? It goes into a distribution system. So now it doesn't really matter what leaves the plant, the treatment plant, does it? It matters what happens next in the distribution system. Have you ever seen them flush out city mains, open up the fire extinguishers? What's that water look like? It looks awful. It's bright red, chocolate milk maybe. It looks awful. So why is that awful? Because that's the distribution piping. It's loaded with sediment, biofilm, everything else. So as soon as you leave that water, and that's the problem with a lot of the countries around the world, their distribution system's terrible. They have to have bottled water because it doesn't matter what water they make. They don't have, distribution systems that they could use. Sometimes the sewer line's planted right next to the water line. So the distribution system, but then also you come into a building. So let's say you're lucky enough to have no disruption, nobody was doing construction in the area, whatever, you come in the plant and into your distribution system, now you got potential problems there too, right? Whatever processes are going on, did the backflow preventer work or did you have some contamination? I was at an automotive plant one time, these guys were complaining about their drinking water, how bad it tasted. And it was a big municipal supply, so I started backtracking where they were getting it. I went back and back. There was a cartridge filter that was in their line that probably hadn't had the cartridge filter changed since they changed models of automobiles. It was black, sludge, you know, it was awful. Well, they were drinking water. It wasn't the problem probably in that case with the water supply or the distribution line. They had a filter that wasn't changed. So carbon filter takes out chlorine, so as soon as you take out chlorine, you got no sterilant. So, you know, from an evaluation standpoint, I don't know what the answer is, but I like tap water if it tastes good, and I think it's got a good source. So right now, a big thing that's going on, do you guys know what forever chemicals are? PFAS, right? So that's a problem, and there's new regulations that are coming out. So one of the things I look at is what's the chance that I have PFAS in the water? That's going to elevate the PFAS that I already have in my body, because I do. So do you. That's another criteria. So what's the chance if I have a well water? Where's that well water? Was it near anything? Was it near an airport? Was it near a military base? Chances are it's got PFAS in it. Well, that's different, you know. So now you have to do all the different criteria. Which is safer? The drinking water. You know, that drinking water bottle, that could have whoever, that they didn't on that, but some drinking water, they just literally fill it up from their own municipal water supply. There's nothing, you know, magic about it. They didn't ozonate it, they didn't RO it, they didn't do anything about it. They just put a bottle on it and charged it 2,000 times more. It's a pretty good business, I think. But in some places, they do a lot of work. They ozonate it, they RO it, they remineralize it, and it's a safer water. So the question goes back to Bryce. It depends. It really does. It depends. You got to look at the source of the water and do the risk assessment. But again, all of that stuff starts with knowledge and knowing what questions to ask and how to evaluate that. In Dayton, years ago, I was on the Dayton Water, what did they call it? Dayton Water Roundtable, Dayton Water Roundtable. It was a group of everybody, industry, you know, all around doing water, you know, improving water quality, water awareness. We did stuff at Boonshoft, put in a water museum and made the Rivermobile for UD to teach kids all about water and rivers and stuff like that. And they had this thing at UD called Bring Back the Tap. Instead of drinking water, having all these water bottles, because you know what one of the big concerns about water bottles now are drinking out of water bottles? So you got PFAS in the drinking water, but you got microplastics in those bottles. Now they're real concerned about microplastics. So you're like, I don't even think I'm going to drink anymore. So they had this thing, Bring Back the Tap, promoting, you know, let's not have all these plastic bottles, you know, plugging up the oceans and stuff. And they had a taste test. It wasn't them that did the taste test. It was a professional company going around comparing municipal waters all over the world and coming up with best tasting waters. Dayton tasted the best in the US, number three best tasting water. They did a taste test against, I forget how many bottled waters, but a lot, like 12, 20 different bottled waters. Guess how many people, or what % of people picked Dayton water over bottled water? 80%? All of them, 100%. There was nobody that picked bottled water over Dayton water. Why is that? Dayton water is a well water, cold lime softened. When they chlorinate it, there's very little chlorine demand, so you're not creating all this taste and stuff from organics. It's a good tasting water. I would definitely prefer it. And if you did a blind test, people that say, oh, no, I like this water, do the blind test, and they'll pick the better tasting water. So how much time do I have left? I have one more little couple minutes, and we start the panel. So this is kind of an ongoing case, and it just started actually for us because I'm working with Solid Blend on it. But there's a local business here who put in a new lab, and they did a bunch of new piping. Okay, brand new piping, replaced all the piping, brand new lab, really nice facility. When you do new piping and stuff, what's the procedure that you use for sterilizing new piping? Where's Doug? or Chris or somebody. Huh? Yeah, the commissioning, but there was where are all those guys? They gave up on me. So there is a standard, as far as new pipe commissioning, but there's a procedure. So much chlorine you have to hold for like 3 hours or something like that.
WWA C651 says you can do 200 ppm for 3 hours or 50 ppm for 24 hours.
Okay. Okay. So they did that. And then they did all the testing. Perfect. Nice. No coliform, no Legionella. All the pipe was done. Everything according. And if you look at the piping, it's all really nice. And then about a month or two later, they started having complaints about water quality in their building. Not the whole building, just the lab area. So they started, talking to their plumbers, yada, yada, yada. I got involved. I went down there and I go, let's test. They already tested water. They sent all sorts of water out to Q labs and looked at iron levels, copper levels, lead levels, bacteria levels, all sorts of stuff. So they had a gazillion data points all over the facility. This is Cincinnati municipal water. It's good water. And if you look at the water quality and the consistency coming out of the municipal plants, it's a 1. It's a good plant. It's a good water. So I was like, it's a low risk water. Walking into it, this is before I even came in there. It's a brand new facility, brand new copper piping. I thought they did a really good job looking up through the ceiling, looking at all the systems and stuff like that. So from an equipment and design, I thought it was good. And the people there, these are all scientists, and they have pipe fitters, on-site facilities and everything else. I was like, this is a low risk operations equipment. But you know what? They started explaining to me all the phone, all the problems that they were having, and at the different locations in the water, and they had some water quality issues. I mean, it wasn't just like turn on the safety shower and a little bit of stuff comes out and then it clears up. They had quite a bit of issues. So they told me on the phone, they told me about how they turned on the lab sink and it would come out clear, then it would get dirty, then it would come out clear and then get dirty and then clear up pretty quick. And I go, that's really interesting, I want to look at that. So I go in there and I said, okay, let's do that. Exactly like they said, that's what happened. And I said, okay, let's turn on all the lab sinks now. They turned on all the lab sinks, and very soon all the lab sinks went extremely turbid for 5 minutes. Not just a few seconds like the other ones, for 5 minutes. Really dirty. I mean, kind of like you're flushing out the fire extinguishers. So you have a problem here. You don't have a water supply problem, you have a problem here that occurred, and it probably occurred by an event or a series of events would be my basis. That was a distribution problem. They had construction in the area, some flow interruption, something that knocked a bunch of stuff loose. So I said, likely you have very low diameter piping. I don't see a lot of stagnation, but you might have some dead legs. You definitely have dead legs in the showers, the safety showers. But I went around and looked at all the hot water heaters, and they had bladder tanks dropped down maybe this far below the header to take out shock, thermal or water hammer and shock. And I go, I'm suspicious of that one. And that one over there. I said, you need to talk to your plumbers, take those out. And I said, if they're loaded with sludge, when you have high flow, it's educting that into your high flow. During your low flow, it just deducts a little bit, and then it goes away. High flow, it's ducting a lot more because it's pulling farther down into that tank. I suspect you have sludge in there. They went to the plumber, they called me, the plumber said we did everything according to code. I said, I told you, remember when I was there? I said, when you go to the plumbers, they're gonna push back. They're not going to like what I had to say because they did everything right, but they're not water treaters and they don't understand what's in water and sediment and stuff like that. So I said, they don't have to replumb it, just do what I said. Close the valve, unscrew it, take pictures, look at sludge in the tanks, sludge on both sides of the valve. So they did that. The one was fine. The other one was totally filled with black sludge. Totally filled with black sludge. So I don't know if that's going to solve the problem because I think there's other low points probably too. But we're going to do all that. Then we're going to go in and we're going to treat it again, probably with biofilm control, chemistry, chlorine dioxide, something, and we will sterilize the whole system. Okay? So why am I telling you this? Because just because it was a low risk water, low risk operation equipment, and low risk operations and control doesn't mean we don't have problems or potential problems, and it doesn't mean that you can overlook all that stuff. So the one last point is, last week I was at the AOAC. Do I have a slide on this? I think so. Yeah, we'll talk about testing a little bit. So I was at the AOAC. Janet's an expert on Legionella testing. I think there's new test procedures, qPCR, and I don't think they're very well known yet, and there's advantages and disadvantages of both, and I think we want to have access to both, especially the quick, rapid response of qPCR. So we are asking AOAC, the Association of Organized Analytical Chemists, who do certification, validation certification. So a procedure can be certified by them, and then if you want to do that procedure, you know it's a valid procedure, that it's accurate and it's good, and it does what it says it's going to do. So I want that because I want to be able to do quick response. If you're doing a remediation, I want answers in 4 hours, not 3 days or 5 days or something like that. I was talking to Bryce earlier. This is the method that we're using with Q Labs right now. They have a live dead viability procedure. I know Janet has used some on their PCR work. Some are better than others. I think this one's good from what I've seen. I saw the self-validation and I saw data from Q. So we can do live dead, get quick results. It reads in GU instead of CFU, but I think that's a good thing, really. It's different, so you don't try to say, if it's 1 CU, how many GU is that? You can try to do it statistically, but it doesn't work like that. They're two different test methods. So I wanted to bring that up. There are new test methods. It's new information, and at the AOC, after I made my presentation and I was part of the panel, one of the questions is, what do you want to see from regulators? And everybody answered. And by the way, CDC was on our panel too, so she's involved with this. I said what I want to see from regulators is for them to be informed. So if information is doubling every 12 hours, I'm pretty sure qPCR data isn't doubling every 24 hours, but it's a lot newer today than it was 5 years ago or 10 years ago. And I still see a lot of people basing decisions on old information. So look at new information, that's what I want. In biofilm and biofilm control, whether it's in cooling tower or in building supplies, to me, the dirty little secret around all this is the first question to ask when I'm doing sampling and I'm looking at all my data is, what was the steady state of biofilm when I took that? And I was talking about this earlier because it's all about biofilm. So if you look at how biofilm gets established, you don't have anything, brand clean system. You got these little bacteria, planktonic bacteria. Some of them take hold on the surface and then they start growing. Okay, so it went from planktonic to this colony on the surface, biofilm. And the advantage, there's a big advantage for the biofilm. First of all, they synergize like Janet was talking about. So they create, and the Montana State University a number of years ago presented a study that they showed that demonstrated that biofilm, every biofilm is in a unique organism because they share a genome, they share DNA. They create their own monster, which means, well, that might tell us something, you know, but they synergize, and you know what? Biofilm has an advantage over planktonic bacteria because the water passing through that is continuously providing nutrients to that biofilm. So they can pull out of all these sandwiches going by to keep their party going. The poor guy that's floating along there, he's getting starved because he can only grab the sandwich that's next to him, so he doesn't get all that replenishment of nutrients, okay? So then the biofilm grows, and how far is it gonna grow? It's gonna grow until it can't grow anymore because of shear force. So it's gonna be there, and you want it to be very thin because people just should accept that biofilm's there. It's in the water, it's on our bodies, it's everywhere. But what happens is, if you have stagnation, like Janet showed, the biofilm gets thicker, then you start flowing again and you slough off. And that's where you get the Legionella. That's where you get high counts, heterotrophic plate counts, like they're seeing here at this example that I gave. And then it goes back down to steady state. So in a water supply system, when you're testing, the first question is asked, when did I test? Was there flow? Was there water hammer? Did somebody use a big thing of water and shut it off? Because as soon as water hammer comes, you could have gone from 30 PSI to 500 PSI or 2000 PSI somewhere and just knocked the crap out of it. So the dirty little secret on this, and this was one of the questions I got asked at the AOAC conference, was from a lady who did remediation work for New York City Public Health. And she got up and she goes, I have a few questions, but mostly comments. And my comment is sampling and isolation and the importance of that. And I said, I'm with you 100%. Because the dirty little secret is in water treatment and cooling systems, so many things can affect that biofilm. So you don't even know if you're not the water treater when all the chemical goes in, what changes occur, the process changes. There's so many factors that can influence the release of biofilm and therefore the release of Legionella. So just one data point. I said, I'll bet you, and I've never done this because nobody ever gave me money to do it, but if I did sampling 24 hours, I bet you I can get 24 different answers. You know, so if they're all 0, that's good. But otherwise, there's a lot of things that influence things at steady state, especially in treated systems. In building supplies, not so much because you're not treating it unless you're doing secondary disinfection or changing temperatures and all those kinds of things. But there is a factor of steady state that I think is important to consider. Thank you, thank you.
Thank you, Dave. We had one question actually come in on the virtual, and it was, what is PFAS in water?
Well, I'll start by telling you a quick story. I was at a plant that makes PFAS just not too long ago because there's a huge remediation that I'm involved with there. And the plant manager said that a lot of solar energy is coming from these panels made in China, and they used to coat and seal all these panels with PFAS, with polyfluorinated alkaline polymers that are forever chemicals. They don't break down very easily, biologically and so forth. So they last forever. And they have a lot of interesting properties. That's why your non-stick pans are sprayed with, so next time you have some eggs, enjoy your PFAS, okay? Or, you know, your clothes, or the pizza box that came and the pizza slides right off, it's got some forever chemical keeping it from sticking and going into the box. They're eliminating that, but there's a lot of uses for it. And he said, you know, one of the very good things is you could give a 20-year warranty on a solar cell or solar panel because it was sealed with PFAS. They're not anymore, and the polymer is probably going to last 5 years, and then your solar panel is going to fail. Well, that's not good. He said, but they still give 20-year warranties because most of those companies won't be around 5 years from now, so they still give the warranties. So PFAS is a chemical that's used in a lot of places, polyfluorinated alkaline substances. It's a fluorinated polymer. It's just very, very persistent, and it's everywhere now. So it's in just about, the only place that they didn't find it was on this one small, and I don't remember what it was, remote island where people have zero, you know, it might have been Papua New Guinea, I don't know, somewhere where they don't even allow people on. But anywhere else, it's everywhere because, and so the new regulations that they're proposing is low parts per trillion, you know, really, really low levels because now they're concerned about the health effects of PFAS. So a lot of municipalities in the past accepted like landfill leachate waters, but what's in landfill? Pizza boxes, you know, clothes, all that other stuff. So now all the landfill leachates have PFAS in it. They used to take it, they treated it good enough to give it to the municipality to drink or to treat the rest of the way. Now the municipalities say, I don't want that because I don't have a technology to take out the PFAS, and now I've got this new regulation. So all these landfills, these 2,000 landfills or 5,000, whatever we have around here, they have leachate, they have water runoff. Now what are they going to do with it? A lot of them are going to deep well injection because there's no other way to treat this PFAS economically. I mean, there are treatments, and that's what I was involved with. They have a very big plant that they're doing it at. So that's PFAS. It's way off subject. Thanks for the question, whoever you were.
So again, thank you, Dave. Real quick, guys, we'll do the trivia questions. What does the H and pH stand for? Correct.
Hell
right here. Hydrogen ion is the correct answer. Oh, yeah, that could be. Question number 2. Groundwater in the Miami Valley is found in an underground river. True or false?
See, I know that this military thing went way past 20 minutes.
Anybody want to throw up a hand for a gift bag? Rob? Rob says true. Answer is, as if I don't know, false. It occupies, listen, the water in the Miami Valley occupies tiny pore spaces in sand, gravel, and rock fractures. Aquifer. Question number 3. I don't know if he touched on this or not. When did Langelier invent the LSI, or the Langelier Saturation Index? She guessed C, 1966. That is incorrect. Anybody else? She guessed 1936. She is correct. So real quick, guys, we did not have a scheduled break, but we're going to take about 10 minutes and set up for the panel. But real quick, a couple things. A couple of you have asked about CEU credits. So the QR code on your table tent, you can scan that. That is actually a survey to the event. We're going to hook you. As soon as you get done with the survey, you can do a check mark for the CEU, enter in your information, and then we'll take care of that from there. So scan the QR code. There will be an email that comes out to you tomorrow in case you don't do that today. Reminder on the passports, if you haven't done that, we do have some in the box already, but if you haven't done that, don't forget to put those in. I wasn't the only bad worker today, so we forgot to give you guys 2 drink tickets, so you wouldn't have had to bought a soda. So we're going to provide you with 2 drink tickets as we set up for the panel. For the social hour, there's going to be beer available. We also do have some custom-made solid blend labeled beer that Grainworks did for us. Everybody has the opportunity to take 4 of those beers home. So we got all those for you as well. So take 10. I'll call you back in. We'll do a panel, and we're looking forward to it. Thanks, guys. Chair all day can be kind of brutal. But just if you could keep it down a little bit. So what we're going to do right now, we've got about an hour left until we need to kind of start tearing down. Social hour will start. What we wanted to do was we wanted to have a panel opportunity. We didn't have a lot of Q&A time throughout the speakers throughout the day, so we invited them all back up. We invited a couple what we thought would be really value-added people to bring up in front of you guys that you could ask questions to that have a lot of experience in water management and facilities, new construction, and that kind of stuff. So I don't have bios for Shannon and Danny. I will do my best, and then they can correct me. So Danny McLeod is with Kettering Health Network. He is the Executive Director of Facilities and has been with Kettering for about 42 years-ish, ballpark. Danny also, probably within the last several years, has become a life safety surveyor for ACHC. Used to be HVAC, now it's ACHC. So he's got a lot of knowledge on facilities from a water management perspective and other perspectives. He also brings to us that kind of HVAC and ACHC side of what are they looking for, you know, what kind of issues are they seeing and those types of things. Shannon Drake, I don't know Shannon's background beyond Danis because that's when we met. So I know Shannon is involved with APIC. That was actually the person that we kind of reached out to get us linked up with them and get the CEUs for the event. So she is an infection control practitioner. She is now with Danis Building Construction and has been for several years. And so she kind of brings that infection prevention standpoint from a new construction renovation perspective, plus her background prior to being with Danis Building Construction. So basically what we would like to do is open it up. Anything that you didn't get answered today specifically that you brought with you, that you had questions on, anything from a question standpoint as far as from your experience in construction, microbiologist, water treatment, Department of Health, Legionellologist, water safety, so all of the topics that we have covered from a reactionary standpoint of, man, we didn't do this and it kind of bit us and then we had to respond to it, or a proactive, hey, we've been doing this for years, it's really working well for us, or just general questions. So we're going to open it up to the group, hoping you guys have your question cap on. We have up to an hour. If the conversation kind of dies out, we don't need to force it. So just wanted to allow an opportunity. And I want to walk around with the mic. There'll be another mic floating around so that the folks that are virtual can hear us as well.
This is regarding something that Dave spoke about earlier regarding RO water. So at Cincinnati Children's, we are in the middle of a construction project. So related to RO water in SPD and sterile processing, can you elaborate on the EPA requirements? Is that a requirement overall, or can you just speak about what those requirements are in purging? And maybe, Shannon, if you can kind of speak from an infection control standpoint on your knowledge and expertise in that area.
Well, I don't know from that standpoint. I know that ROs and equipment, when you're talking high sterility, they're totally different than industrial ROs. I'm mostly industrial ROs. So the piping, the procedures and all that stuff, it is for high purity. I mean, so you're minimizing the risk based on the design of it, the procedures that you have to follow and all that stuff. I don't know what those are, but the company I used to work for used to build it like that, but I wasn't personally involved in the requirements for it. I do know that if you need an anesthesiologist at Children's, my son-in-law is an anesthesiologist. And yeah, so, but from an RO standpoint, the operations of it, an RO is it's used in a lot of high purity because it's not a filter, it's reverse osmosis. So it's leaving behind, as long as you don't have breaches in it and brine seal problems and stuff like that, it's leaving everything behind, all the biological portion of it. So it's a good strategy to end up with biologically clean water too. After that, then there are procedures to keep circulation, use UV and other things to make sure that you don't have biological content exceeding whatever you have to accomplish in the ultra pure water afterwards. But through the membrane itself, it's a good barrier.
I would just tell you from an infection prevention standpoint, make sure that it's working the way that it was designed, that it hasn't been tweaked. There's with good intentions. Sometimes, whether it's facilities or people that work in the department will go and tweak it because I needed it to give more pressure. I needed it to do something that it wasn't really designed to do. So just make sure that it's working in the right order, and don't forget about it with your water management plan too, because if everything is working the way it's designed, then your risk is a lot lower. But a lot of times things happen with good intentions that end up causing problems.
I might add on that there are different procedures for that, and there are also different designs for that. They call full fit. Membranes generally don't like high temperature, right? So reverse osmosis membranes usually have a fairly low temperature because it's going to dissolve the glue seams in the membrane, stuff like that. There are membranes that are made for high temperature and the design for high temperature so that you can go through thermal sterilizations also. And so that's, again, a procedural thing that you want to make sure you're doing it. So it's going to be made out of stainless steel, probably 316 stainless steel with, no dead legs, good, smooth elbows and all that kind of stuff. And it may be a full fit thermal type membrane so that you can minimize the risk of even developing bacterial growth, even if it is a barrier for it.
So specifically dealing with sterile processing. So when you have RO, usually for your instrument sanitation, cart washing, you're looking for the manufacturer of the cart washer to provide you with the parameters for the water has to meet this quality. It has to be this hardness, none. It has to be this alkalinity, this TDS. So the manufacturer will provide that. On the other side, you want to do the bacteriological monitoring, like Dave said. So for instance, there are specific standards for the washing of medical equipment that would say, this is what you need to test for. These are the limits. So HPC, TOC, endotoxin. Again, you're looking at two different things, but it's all for the same process. And any water treatment company should be able to walk you through that. I'd be happy to.
Just a quick comment. This discussion reminds me of what you were talking about, Dave, where you were talking about turnover of people working. So in the endoscope processing, scope reprocessing, what I've been told is that it's a very complex process it's difficult to follow the manufacturer's instructions for use, IFU. And so there's a lot of turnover, which really, if you ever get scoped, I want you to remember this conversation because it's a little scary. But it's specialty water, to Doug's point, and then there are different organizations that establish those standards, like ASSE Standards, and the current standard ST108 is being revised. And so if anybody here knows when the new one's coming out, it's 34. I keep asking, and it's kind of like this. It's in committee kind of thing, and so we're trying to like get it done. It's sort of like the ASHRAE experience that I have. It took 10 years to get the ASHRAE standard. So just keep that in mind, that there are instructions for use in certain organizations that cover the quality of that water for specialty equipment. Mm-hmm.
Hi, I'm sorry. I got the mic. For flushing protocols, faucets that are metered or push button, do you have any suggestions for implementing flushing protocols for those more difficult faucets that you can't just turn on?
Yeah, that's a challenge, and I know that those kinds of faucets and showers are in like correctional institutions or mental health or things like that where they can't have handles, worrying about ligature. Well, first thought that comes to my mind, and I said it earlier, is that you have to understand what to expect from flushing, right? Flushing's not going to convert a system or a fixture from Legionella positive to Legionella negative on an ongoing basis. So the goal really is either to move disinfectant through that fixture or just to improve overall hygiene of the water. So the bar is pretty low on what you can accomplish with flushing, and so you just really have to understand the purpose of that. As far as guidance on time, I've been disappointed actually with some of the publications, like one came out from AWWA, American Water Works Association, and IAPMO, where they wrote a whole thing, like a guidance document about flushing in building stagnation, and there was really no specific information. Okay, somebody just tell us how long, would you? And so some people will say 2 minutes. Some people will say 5 minutes. I've seen something 30 minutes. So I can tell you that in our own experience in doing sampling, if you flush for 2 minutes, which used to be part of the CDC recommendation, let the water flush for 2 minutes, and I'm just like, no, take immediate draw hot water, please. But what we did was we compared that with immediate draw hot water. Immediate draw hot water gives you the most reliable answer to is Legionella present. But when we flush it for 2 minutes and we come back the next week, it's as if we didn't do anything. So Legionella's just there hanging out. It's really what you decide, and this really didn't come out too much in the discussion of what the water management plan is. Nobody tells you the specifics that have to be in your plan. It's your plan. We've given you sort of the paradigm, the rubric, the template of requirement, extremely general requirements and recommendations from CDC and ASHRAE, but it's your plan, what you decide. And the surveyor is going to look at what's in your plan. Does it check off, what's the general elements that need to be there? But if you want to do flushing for 2 minutes, just document that you did it for 2 minutes. If you want to do it for 5 minutes, just document that you did it for 5 minutes. So there's no real good studies out there other than saying that after you flush, Legionella comes back. You have a very temporary increase in your oxidant level. If you got chlorine in the water, it might go up. But then it's going to go back down as soon as the water sits there. So I'm not going to say make it up, but that's what everybody else is doing. They just give a number, and it's really not really scientifically based, but it helps move disinfectant through the system. So for example, if you had monochloramine as a supplemental disinfectant or chlorine or copper silver ionization, whatever, if you aren't measuring it and then you flush, you take a sample to measure, now I've got it, you're good. And whatever time that took, you're good.
I thought it was how long it took to sing Twinkle, Twinkle, Little Star.
Twinkle, no, that's happy birthday. That's hand washing.
I can add to from the facility side, and we're so lucky in the Kettering Health Systems. I have 7 monochlorine injection systems due to things that have happened, and really we went to that because of being on the proactive side instead of reactive side, because 2 times I have been so the lucky one of the reactive side, and that's no fun when you're buying 1,700 filters and chaos for nursing and chaos for surgery and everything else, and physicians never understand it. So one of the things that we're doing, though, with these systems, and I think Dr. Stout mentioned it, we're flushing as the environmental service team is in areas. You know, you're in the hospital, we have showers everywhere. But today, if you can take a shower, most likely you're not in the hospital because they're kicking you out, because you only have to be allowed to be there so many hours or days, or, you know, depending on what that procedure is. If you're well enough to take a shower, that means you're out the door. So showers are a big challenge for us as far as, so if they are used, so many times they just sit there. Some of them has the wands and then they're hanging down, so we leave them, but you still got to clean them. So on the flushing side, we've engaged our environmental service team in areas that to help us. Every day that they're in there cleaning, run the water. Doug, you may remember, is it like 5 minutes we're trying to run it, or?
So what we have compiled is, on the hot water side, you take the hot.
Thank you. On the hot water side, you take it until the temperature stabilizes at its highest point, and then flush for an additional 5 minutes. Once you do that, you have kind of the baseline that this wing, generally 7 or 8 minutes will accomplish that without checking the temperature every single time. Same thing on the cold side. You get to the coldest point when it stabilizes, go an additional 5. So it kind of puts time in that.
I guess, like, how do you achieve a 5-minute flush time for a metered faucet is kind of what I was
right.
getting at.
Right. So on the there's a love-hate relationship with the hands-free. During COVID, everybody thought hands-free was great. From a facilities maintenance standpoint, they're a nightmare because you have to have this, the battery goes out, all these things. So there are a few manufacturers, Chicago comes to mind, that you can actually purchase. It's not inexpensive, but you can purchase one that can be programmed to have a hygiene flush. So it will automatically flush, and you can set the time parameters for, I believe it's anywhere from 3 minutes to 168 minutes, and you can do that in increments of 1 hour, every 12 hours, every 24. The trick with that is you need to make sure there's nothing in the sink that could possibly block it, because then facilities is coming, nursing's coming, they're having problems. Other than that, what we have suggested to some folks, if it's a short-term thing, is to say, hire a temp or get somebody from EBS, and that's their job. They go and they stand. And they do this, and I'm not kidding, because some people say, well, I don't have the staff to do that, but you can find ways to make that happen, especially if we're doing temporary monochloramine. You have to flush water through every fixture every day. So, you know, your maintenance staff is busy. You need to bring somebody in because it has to be done. So you can get them programmed. Honestly, it's better to go back to the two-handle.
The Ohio Plumbing Code requires disinfection of new water distribution systems before they're put into service. Okay, we enforce that at Franklin County Public Health. It does not distinguish between the commercial application and the residential, the 1, 2, and 3 family dwellings. So there's a big controversy right now. And is there any data that anybody knows of that would give an exception on the 1, 2, and 3 family side? People saying that, well, we've never had an instance where we've had Legionella or any kind of documented experience of Legionella on a single family dwelling. Okay, and just kind of curious if any of you have had any experience in that area. Is there something there that might say we don't need to do this disinfection on 1, 2, and 3 family dwellings?
So I can speak to research that we did back in the 90s, because we knew hospitals had, at least half of them had Legionella in them. And so we asked the question, would single-family dwellings in the Pittsburgh area also have Legionella? So we enlisted the American Legion to help us with the study, believe it or not. And because I was like, who's going to let us into their house to take blood and urine and sample their water? The American Legion, of course, from their interests. So almost 300 homes in the Pittsburgh area were sampled, and less than 10% of them had Legionella in them. And the ones that did were in an area where there was a lot of iron pipe, interestingly enough. And so we documented that. And that was published in, I think, Epidemiology and Infection. So I'm happy to send you that article. So from that, we established initially that the prevalence of Legionella in smaller single-family dwellings was much lower than larger, more complex buildings. Then we did another study funded by EPA, which actually included the Cuyahoga Health Department, where we asked the question, we're going to go backwards from, you've got Legionnaire's disease, is it in your home? And about 20% had Legionella in their home, but the people that got Legionnaire's disease were at the very susceptible. One guy was recently diagnosed with leukemia. Another was an elderly woman undergoing chemotherapy. So the concept is Legionella was always there. What changed wasn't Legionella. What changed was the health status of the person in the house. So when we've written about this, we say the risk is extremely low. So I'm happy to send you all those papers. Mm-hmm.
Just to kind of add to that, just from the contractor side of it, I know it doesn't say that you have to do it, but it also doesn't say that you don't have to do it. So for that whole legal aspect of it, we don't do a lot with Danis. We don't do a lot of residential builds. We're more on the commercial, the healthcare, the food and bev industry side of it. I'll tell you that we do it we do the chlorination in every project. The Legionella testing is a little bit different. It depends on the type of clientele that's going to be in that building. If it's a healthcare, we 100% of the time will test for Legionella, just to make sure that we can tell the owner that we're turning over a clean system at the time we handed it to you, and here's what you need to do to flush it to keep it going. And then any congregate area where you don't know what the health status of the people are. So dormitories in universities, you have no idea what the health status is of anybody that's in that dormitory. We would do it there. Any type of drug and alcohol rehab, they tend to be a little bit more immunocompromised because of their status. We do those there too. So yeah, I mean, it's low risk depending on who's in the household, but just because it doesn't say to do it, make sure it doesn't say not to do it too. So
and
kind of depends.
One other caveat. So these are all, single-family homes built whenever. They're not part of a big development. And I'm aware of one public health consultant who, it was a big development. You know how they add houses one at a time in these developments, but the water is like just sitting there sometimes for years? They had lots of Legionella in that water. So that might be another caveat. If it's part of a big development, where they're adding over time, the risk might be higher. If you run out of questions, I have some.
One from virtual. Here we go. So this is like a two or three stage question. Bear with me. So after listening to all of the speakers, it sounds like water can be unpredictable, to say the least. What can we do to protect a building when the water conditions constantly change? Whole building filtration, secondary disinfection, both. Is there a silver bullet to prevent from producing negative Legionella? I'm trying to read this correctly. Is there a silver bullet to keep producing negative Legionella sample results, i.e. no sick people? Is there a silver bullet, I think is the question, with all the dynamics that they've heard today?
No, simply no. But it really depends on the facility's setup as a whole on the best way to do it. But if in terms of what you could do proactively, I believe it's been said by every speaker, water management program. some form. That's the best thing you could do proactively, is have something set up, identify those areas of risk for your specific facility, and then set up some form of monitoring so that you're checking regularly. The question asker also mentioned samples, which is how you determine whether or not what you're doing is actually working. So that's good as well. But not only having that in place, but regularly adjusting it as more information research comes in and as your building changes, and to adjust for any other changes in the water supply, though I'm sure that some of the other panelists have more to add on that.
One of the things that we're doing in our hospitals is up in the floors, farthest points away from where our water is heated, down in the boiler areas, and our domestic hot water travels out. We're testing the temperature of the water out in the facility, because I think one of the speakers spoke about there's that perfect gem of where Legionella loves to grow. And Doug, you can correct me if I'm wrong, we're looking at maintaining over 105, or right at that, our point of distribution out in the facilities. So it's one of the things we're doing proactively as we just check throughout the facility. But add to that.
So Legionella grows rapid. Oh, she's killing me.
Right? Somebody's got to keep me on track here.
Everyone wants to hear what you have to say.
So yes, whatever you have in your plan, as that is what your control range is for temperature, you have to be monitoring that, and you have to be verifying that that is what it says it is. And we see this range. Now, one thing that we have learned recently in discussions with the Ohio Department of Health, they would like to see those points of use higher. What I typically say to our partners is, you want to get as close to 120 as possible without going over at the point of use. So if you have a hot water tank, you want that to be 140 degrees minimum. But at your points of use, you want to see that get higher. So there's numbers that get thrown out there that are 113, 114. What is it? Remember, there's three parts of that, not just the temperature. You've got your temperature, you've got your residual disinfectant, and flow. All right, so you're checking all of these things, pH, all of that, to see, are we turning the water over and not accumulating water age?
Just a couple things. On the incoming water quality, the question was, understanding there's variability. If you've never tested the residual disinfectant or any of the other parameters of the water coming into your building, at least establish a baseline there. It does change. The municipality increases, decreases, disinfectant levels, that things can happen where maybe for a while you're at your target and all of a sudden it drops down. And if you're monitoring that periodically, then you can, not saying it always works, but you can call the municipality and say, this is my location. You're supposed to, by EPA standards, be delivering this amount of disinfectant and we're not getting it. Would you like to fix that? And sometimes they say, we'll be right on it. And other times they'll be like, let me put you on hold. So that's something that you can monitor and have some communication with your supplier of your source water. The other part of the question was point of entry filtration. This is what I say about point of entry filtration. So we're really data driven. It's in medicine, it's evidence based. Like, what's the data that tells me that doing that is going to make any difference inside my facility with regard to either Legionella risk or anything else? And as I sit here right now, but the future may change, and what I'm saying now might be wrong in 12 hours. There's no good data in terms of studies that have looked at the impact of point of entry filtration on those endpoint parameters. So conceptually, it sounds wonderful, right? It's going to take out some particulates, which are bad for equipment. And so if that's your goal, go ahead and put it on. But again, it's sort of in the category of managing expectations. Understand what it's going to do and what it's not going to do for you. And maybe next time we all get together, there'll be more data published in the literature that sort of puts some parameters together around that. But just remember, any piece of equipment you put in requires maintenance and people to do the maintenance. And so you want to make sure that if you're going to put something in there that's going to require facilities to maintain, make sure your vendors are taking care of it and all of that, that you evaluate that as part of the decision as to whether or not you're going to put this piece of equipment in there.
I did want to walk it back a second to what Doug was mentioning earlier, just in regards to, he mentioned 113, 114, 115. Really, they say different things everywhere. Currently, Janet mentioned in her talk the CDC control toolkit that was published in 2021. That does offer specific numbers. I think it says 113 right now. Yeah. So that is helpful, and it's important to consider that it's not just the temperature. That's not going to be enough on its own. And even then, Legionella, the bacteria actually doesn't start dying off until 127, so above where a facility can actually turn it, and it's not effective till it's around 140. So it takes all of that, and that's why we say there's no real silver bullet to it. You just have to kind of see what works for your system through validation. Well, we can't require it, but through validation testing is the best way to check if Legionella is actually still present at a high level.
I could tell you from experience, if you were today or any point forward were to submit a water management plan with a control temperature, control range for a hot water distal fixture any less than 113, you would probably have a question from the Ohio Department of Health. And again, that's the CDC's current recommendation. These things change all the time. So at one point it was this temp, but we're always trying to be up with the most current science and the most current guidelines from the folks that know. So currently 113 is the bottom end for a hot water fixture. If your plan says less than that, as long as you're maintaining that, you're fine. And then when it comes time to revise your plan, which you should do every year, you can change that and move that up.
And we have many masters, right? So whoever is the authority having jurisdiction over your temperature, delivery temperature is, you want to be careful because there are safety issues around scalding that the code will say you can't be above this temperature. So you have to be careful. And you're not going to control Legionella with temperature in most of these facilities, especially if it's healthcare. You can't keep it hot enough. So again, managing expectations. It's best practice, but manage expectations in terms of the outcome.
You guys discussed a lot about disinfection and putting permanent systems in. Can you touch a little bit on some of the drawbacks of like monochloramine over time? Because it's my understanding that Pseudomonas can kind of rear its ugly head with monochloramine. Is that correct? That it may not be that effective against that? And my last question is going to be, we still see copper-silver ionization systems going in, and I've not seen really good results with that in some of the literatures all over the place. So any comments on that would be great too.
Can I go first? Ladies first. One advantage that we have for Women's Month or whatever it is. So monochloramine efficacy against different bacteria. So if you have the proper concentration, it's like, we live in water treatment, concentration times time. And microbes will have different susceptibilities, but if the concentration is adequate and the time is adequate, most of the bacteria, including Pseudomonas, will be controlled with monochloramine. One exception, which is the highly, highly, highly tolerant bacteria, the non-tuberculous mycobacteria, they, based on our studies and also the studies in Ohio, you basically are holding non-tuberculous mycobacteria in check with monochloramine, and even chlorine is even less effective at the levels that we're usually using. So you should be able to control these organisms at our targets are 2 to 3 parts per million for monochloramine is optimal. 4 is the maximum allowable. If you get down below 2, you start to lose efficacy in terms of Legionella and other organisms. Copper-silver ionization, so at the Pittsburgh VA Medical Center, we were the first really to study copper-silver ionization. And then many subsequent hospitals, we actually queried 16 different hospitals. We called it the Sweet 16. It was not during March Madness, by the way, but we called it the Sweet 16. And those 16 hospitals across the United States that were using copper silver, we asked them a simple question, were you maintaining below 30% positivity? Were you not seeing cases of Legionnaire's disease in your facility? And the answer was yes. But with every disinfection system, regardless of the type, if you don't manage it and maintain it and keep control over it, meaning the right concentration, keeping the systems operating according to the instructions of the manufacturer, you're going to lose efficacy. So ionization works if you operate it properly. And that's not Dr. Stout's opinion, that's the published literature. CDC, this is sort of an interesting thing. During the Pittsburgh VA outbreak that occurred after we left, by the way, they weren't maintaining it properly. And in the CDC report about that, they said ionization didn't work because they didn't experiment in the laboratory to show this. Well, they had to publish a correction because the Post-Gazette reporter, through the Freedom of Information Act, got the internal communications where they decided to not publish the data point that showed that ionization worked. They said before 24 hours, so it's a truthful statement, there was no change. But they had the next data point that showed that there was, but they chose not to report that. And as shocking as that is, they got caught. But lots of people refer to that paper to say ionization doesn't work. So you just have to be careful. And if you're a Legionella nerd like me, you know all of that detail.
So would that be a copper silver bullet?
Yeah, right. No, that's cores, the silver bullet.
Okay.
Yeah.
That's a copper silver bullet, I think. No?
Okay. Are we all good? Oh, we got one more. Lindsay's coming to you.
Hi, so this question's probably more for Bryce. I was wondering if you could elaborate just a little bit more on the different definitions of either presumptive, positive, healthcare-associated Legionella, possible, and all of that.
Yeah, so I could sort of answer this. Ellen's usually the one who talks about it when we actually have calls, but I've heard it enough. So yeah, there's the confirmed case, which there's kind of two different types. So when we're just talking about Legionnaire's disease, there's the confirmed case, which requires like chest x-ray of pneumonia and UAT or a sputum culture or something else to confirm that that the person had Legionnaire's disease, and that's when it's called Legionnaire's disease. And then there's the healthcare association, which depends on how long in their incubation period they spent at the facility. The definition changed in 2020. They used to call it definite versus possible healthcare associated case. Then I switched it to the term presumptive, just to be more scientifically accurate, basically. But and they also expanded the incubation period, I think 2 days. Yeah.
4 days.
4 days, yeah. I went from 10 to 14. Just so it could include 99.8% of the cases, I think, is where it was, or where it is. So the presumptive is 10 consecutive days of their incubation period. So if they have 10 days where they didn't leave the facility at all, that's called a presumptive case, and that's we let the EPIs kind of base that on their interviews and the information they have, and then that's when we ask for full investigation procedure. So A possible is kind of tricky. So possible is everything else. It can be, it can be a single outpatient visit, which usually would just, if it comes up, we just ask for that basic material. And if we notice something particularly concerning, we might ask for a little bit more. If it could be, they were at a long-term care facility, and have been there for a year. They left a single time 7 days from onset for a doctor's visit for 2 hours. And that's still a possible case because it wasn't 10 consecutive days because that was right in the middle. Then we asked for basically everything, but not filters. And then everything in between, we're kind of working out the specifics on when we ask for what and discussing it. But we just add a little bit more each time, and it kind of depends on what the facility already has in place, how their water management program is, because they never quite feel comfortable closing an investigation without a solid water management program in place. So kind of all that. I hope that answers your question a little bit.
I was going to say, and if there's no, Michael? Yeah, is that all right? Yeah, no, it's not okay.
So I'm interested from a new construction perspective. So you've got engineers and architects that design the building, and the contractors, the mechanical or general contractors are building it, and then you're hiring specific mechanical contractors to do the finish work. So maybe ultimately, where does the buck stop when it comes to the design, the construction, and the specialty of like piping a new building? I assume it would stop at the building owner. But then I'm just interested, so it sounds like, Shannon, maybe from a Dana's perspective, you may not be required to, but it's if I heard correctly, it might be a best practice that Dana's Construction wants to hand over a clean bill of health. But that just might be something you guys do as a best practice. So where does the buck stop? And then how do we better collaborate between the people designing, building the buildings and the mechanicals doing the piping? How do we better collaborate to hand over a building in its safest possible condition?
That's a lot. So from Dana's perspective, it is part of our best practice. I will tell you there's not a standard best practice across all general contractors, all engineering facilities across the US. Everyone's kind of doing things a little bit differently. We have had a quality department that has been hyper vigilant about Legionella from before we even really were talking about it. No, I mean, from our perspective, we weren't talking about Legionella until people got sick and died, and then there were legal ramifications from it, right? So whenever you have a case, it's not if you get sued, it's when you get sued from a healthcare perspective. So if the patient unfortunately passes away from it, the family's going to sue you. 99% of the time, you're going to end up in legal problems. So from a business perspective, we want to make sure that we're not one of the ones that are named in those lawsuits. And if you go back on some of those lawsuits, they don't just name the company that was there or just the plumbing company or the general contractor that was there. They will name every contractor, whether they touched plumbing or not. There will be electricians named in it, concrete people outside, and not just the company themselves, but individuals that work for companies. So, and then they let the lawyers figure it all out. We want to make sure that we don't end up there. Ideally, we want to make sure that it doesn't happen so that the patients don't have those issues. But from a business perspective, in order to stay in business, we want to make sure that we don't get named for that. So they decided long before I even started that was part of our best practice, was to go in and make sure that everything was done right. It got chlorinated. The building code gives us a good starting point, but then we build on top of that. There are some contractor organizations that are getting together to try to make it more across the board as being a best practice. It depends on where you are. And we have some of our offices are outside of the Ohio area, and we have a little bit more issues, like we have some down in Florida. It's a little bit more difficult to get some of it across down in the Florida area, just for whatever reason. It's just a different mindset. So you'll come across different mindsets everywhere, but we did make sure that it was part of our best practice. We do get some pushback sometimes because of the cost. What does it always end up? Well, we're trying to cut cost. It was a $40 million project, but we got to cut 10 million out of that, and oh, look what's going to go. We don't have the money in it to bring in a solid blend to do the chlorination. We're going to do it, and we'll find the money on the back end, because it is best practice for us to make sure that we can tell you when we turned it over to you, here's all the results, here's all of your fixtures mapped out, here's what we did, here's our weekly flushing. We made sure that it kept moving because it's designed to move a certain amount of water. You have nobody in it. So, and even those fixtures where they're push button or you stand there and have to like keep doing things, I carry cards in my pocket even when I go out to do those, to put a card in front of those so that I can get like 3 or 4 of them going at the same time, and then you go back and do them again. But we do. I hope that the industry ends up pushing more towards that being a best practice. We'll see.
A couple of resources for people. In ASHRAE Standard 188, this is what I tell people: pay attention to Section 8, which is design and construction. It has some of the most prescriptive language of the standard in Section 8 about what the designer and the building owner need to be doing and what needs to be communicated. Another resource is the ASSE Standard 12,000 has a water infection control risk assessment. So all the IPs here know about ICRAs, and we're very familiar with trying to prevent construction-related dust, really to prevent fungal infections. Well, we've put W in front of ICRA, so it's WICRA, and so that's about the quality of the water impacted by construction, whether it's renovation or a whole building construction. So there's a checklist in the standard 12,000 from ASSE that's just like an ICRA, but it's about water. And it's like, what is the amount of impact of the construction or renovation likely to have on the quality of water? The CDC WICRA really describes water management. It's not really water infection control risk assessment as you would understand it for control of dust. So WICRA, ASSE 12,000, you'll find some checklists there.
I will say on the CMS side, the expectation is that infection control, so one of the things you do proactive as you're designing projects and things across your campus, especially in healthcare, is your infection control needs to sign off on part of the design, the planning, and especially as a project ends, because there's always an ICRA that is put in place. So those sign-offs and things in place are expected from a CMS perspective. When we come on site for a survey, we're going to expect that in CMS for Chapter 7 under ACHC, I'm not sure what it is under the ECs. We used to be Joint Commission, we're no longer. But there's the expectation that they are a part of, and that is a blended with your physical environment and the planning. So it's very proactive to have them involved in the whole project to keep on that safe side, because they live that side, and us facility guys, we always go, oh no, here comes the infection control group. So, but it's very important that they're involved in the planning. And I know when the survey team comes on to your campuses after March 3rd, they're going to look for the life safety surveyor and the nurse together and review your water management plan. It's one of the standards that we've been educated on as surveyors.
So, Janet, I'm going to give you a very quick, so I was just informed and I knew this, and I'm going to remind myself and let y'all know. The doors to this facility are open to the public at 3 o'clock, which is in 12 minutes. We still have our happy hour, or social hour, whatever you want to call it, at 3 o'clock. So I'm going to let Janet ask a question, and then we're going to wrap up. I've got a couple quick things to say, and then we'll cut you guys loose, whether you stay or whether you got to bug out.
So talk fast, Bryce. Here's my question. So when a hospital, it's just the scenarios, they've had a case or cases, they do their short-term remediation, almost 100% of the time in my experience, they have to install a long-term disinfection system to take care of the problem ongoing. There's a permitting piece to this, because now the hospital becomes a community water system. In Pennsylvania, it takes a long time to get the permit handled. I'm interested in what happens in Ohio, and can they install while the permit is going through the process?
I'm not quite qualified to answer this, but I guess I'm more qualified.
But you stayed at a Holiday Inn Express.
I've got that one back.
Yeah, so the permitting goes through Ohio EPA. I know who to contact, and usually we're able to get that process started because we've had multiple discussions regarding the installation of a secondary disinfection system, specifically in response to an outbreak or a presumptive case. We've worked with multiple consultants on helping them through that process of installing that. And I'm sure Doug would be able to talk more in detail about the actual process because once it goes into the permitting stage, then it's more between Ohio EPA than ODH.
Quickly, Doug.
It will be very quick. So yes, case in point, when we installed monochloramine permanent systems into the Kettering hospital facilities, we applied for the permit. They allowed us to install and operate, not necessarily under a temporary permit, but pending permit approval. You have to go through the plan submission, the approval, the comments back and forth, the inspections and all of that. That can take anywhere from 6 months to a year and a half. And the thing is, what we did, we weren't necessarily told to do this, but because we had two systems that were previously permitted, we knew the standards, we knew what we had to do to be in compliance. We just treated these that were pending as if they were permitted. So, and then you go through that, but that is the Division of Drinking and Groundwaters, EPA. We have an example unit right there. If anybody wants to talk to me afterward about monochloramine and those things and the permit process, happy to do it.
Let's give a big round of applause to the panelists. Thank you guys so much for all the knowledge that you have shared with us today. We really appreciate it. Couple quick things. Did everyone get their passports in that wanted to? Great. I'm going to draw those here in a second. Big thanks to everybody for coming. A lot of content today, drinking from a fire hose, but we really appreciate it. We're going to double check with the speakers about sharing presentations. We've recorded the events. We've just got to do some checking on making sure we can share that stuff. Special thanks to our co-sponsors, APIC and TSHE. And a big thanks to all of our vendors here, Aerobiology Labs, Special Pathogens Labs, AP Tech Group, Becker Engineered Systems, Nephros, OBR Cooling Towers, Sanapure, Q Labs. As I said, social hour starts basically now. Reminder, if you haven't gotten your 4-pack of beer, please do so. Don't forget your drink tickets. And special thanks as well to OBR for sponsoring the social hour. Thank you, OBR. We appreciate that. No, give me juice. Oh, Lindsay's waving at me. The seat cushions are yours to take home. Think of us when you're sitting at a football game. Think of water. So I'm going to walk around. I'm going to have somebody just grab these. I'm just going to say first come, first serve. So if you're first up, there are 4 $25 Amazon cards and 4 Yeti cups. And last person gets whatever is left. I will let you draw for me. Adam Holbrook. She drew for her best friend. Will you draw one for me, please? Christopher Johnson. What's going on around here? Should I have a different group draw? Will you draw one out of there for me? I've got Mary Terrell. Yes. Yeah, just sit. Will you draw one out of there for me, sir? We've got Marissa Walterbush. If I, you can grab it for her. That's fine. Take it with you. Let's see. Chuck, will you pull one out for me, please? There you go. How many do I have left up there? Emily Norris. Emily Norris. How many's left up there? Would you mind pulling one out of there for me, please? Angie Bowman. Just set it down, thanks. You mind pulling one out of there for me, sir? Thank you very much. I think there's one more after this. Angie Dwyer. And one more. Let's see. I'll let you draw the last one, sir. We've got Suzanne O'Rourke. Come on down. I think that's it. Thank you all so much. I hope you can stick around and have a beverage with us and chat a little bit more. We appreciate it. There you go. There you go. Thanks, Mark.